اتفضل يا دكتور خالد.
ايوه تمام. اول حاجه كل سنه وانتم طيبين يا جماعه. خلاص دخلنا العيد.
وانت طيب يا رب.
وحابب اشكركم مره ثانيه لانكم اديتونا الفرصه دي ان نشارك معاكم. واي هوب انه يعني الليكشر تكون يعني somehow beneficial بالنسبه لكم، تضيف لكم يعني معلومات زياده.
طبعا احنا متأكدين من الحاجة دي وواثقين جدا وشاكرين لك جدا جدا يعني على وجودك الليلة وعلى كرمك.
شكرا لكم، ان شاء الله نكون على قدر الثقه. نحن زي ما قلت لكم هنتكلم ان شاء الله عن الستروك. هي الليكشر هتكون يعني ستروك ان جنرال، وبرضه بنحاول نخليها قدر الامكان MRCP يعني دايركتد، يعني تكون focusing on يعني البوسيبل يعني scenarios اللي ممكن to be related to MRCP exams and so on. لكن stroke or cerebrovascular accident طبعا هو major topic in medicine و in neurology، فالكلام فيه يعني ما بيخلص، يعني في كلام كثير جدا جدا. فنحن نحاول يعني خلال الليكشر نحاول to highlight يعني important points، بالذات في النقاط اللي ممكن تكون جراي شويه لبعض الناس، اللي هي تحديدا الحته بتاعت الكلينيكال فايندينجز والكلينيكال فيتشرز، يعني how to localize the site of the pathology, the site of the lesion في الستروك. هنحاول خلال الليكشر دي احنا نحاول ان شاء الله المحاضره نقسمها على نصين، لانه difficult to cover كل الموضوع كده في سيشن واحده. في السيشن الاولى ليله نحاول نتكلم يعني mainly focusing on the clinical features of stroke، ونعمل anatomical correlation مع clinical features in order to make it easier يعني بعد ذاك. في النكست ليكشر ممكن يعني نتكلم بعد ذاك عن المانجمنت اوف ستروك. فيبقى الستروك يعني as we all know يعني stroke is also called cerebrovascular accident. It's defined as an abrupt onset of a neurologic deficit that is attributable to a focal vascular cause. This is a simple يعني definition for stroke or CVA. يبقى it's an abrupt onset، يعني it has a sudden onset دائما، ويكون عندنا neurological deficit. This is an important point. This neurologic deficit is related to a focal vascular cause. So هنا ال cause of a neurological deficit is a vascular cause. And this vascular cause ممكن يكون in form of cerebral ischemia or it could be due to hemorrhage. يبقى الستروك احنا عارفين it's either ischemic stroke or hemorrhagic stroke. وin general يعني بيقولوا around 80% of the total cases of stroke بتكون ischemic stroke، بتكون cerebral infarction. Well, the remaining 20% of cases بيكون hemorrhagic stroke. Hemorrhagic stroke itself is subdivided into intracerebral hemorrhage و subarachnoid hemorrhage. When you compare the two types of hemorrhagic stroke, out of the 20% of hemorrhagic strokes, 15% are intracerebral hemorrhage, while 5% are subarachnoid hemorrhage. So among hemorrhagic stroke cases, the majority of cases are intracerebral hemorrhage. Okay, this is an initial point يعني we need to know. Stroke طبعا is the second leading cause of death worldwide. And this is how important and how major يعني this disease on health in general. It's the second leading cause of death worldwide. Although nowadays in developed countries يعني with the evolution of stroke centers and stroke units, and also we know that stroke is preventable disease. For that reason, the incidence of stroke يعني has declined significantly in the recent years. For example, يعني in USA, in America, يعني since 2014, now stroke is considered number 5 cause of death, number 5 leading cause of death. And this is how يعني significant the evolution في developed countries, especially when we talk about stroke units and stroke centers. هنتكلم عنها later on في management and how it affects the mortality of stroke. In addition to that, يعني a lot of work has been made in the prevention of stroke because it's a preventable disease. طيب من the definition of stroke and CVA, we can understand that stroke is mainly a clinical diagnosis. يعني we know that we do brain imaging always in any cases of suspected stroke, but stroke primarily is a clinical diagnosis. We do brain imaging to support our diagnosis. And the importance of brain imaging is to distinguish between ischemic and hemorrhagic strokes, because this is essential to guide management. In order to guide management of stroke, you need to do brain imaging. Without brain imaging, we cannot start managing stroke as ischemic or hemorrhagic stroke. And this is a major mistake in our practice, especially in rural areas. Some doctors and some physicians tend to treat patients with a stroke without doing brain imaging. They might start treatment for ischemic stroke without even doing brain imaging, maybe due to unavailability of brain imaging and so on. But this is a major mistake. In order to distinguish between hemorrhagic and ischemic stroke, you should acquire some sort of brain imaging. And usually the initial type of brain imaging that we do in our practice is a non-contrast brain CT because it's widely available compared to MRI. We will talk about the diagnosis and the best imaging modalities to diagnose stroke later on. This is just an introduction. As we know, there is a condition called transient ischemic attack. Transient ischemic attack is also due to cerebral ischemia. We compare transient ischemic attack with a stroke, with ischemic stroke. The difference is in transient ischemic attack, the neurologic deficit which develops due to focal vascular cause, it tends to be transient. So there is transient cessation of blood flow to a specific part of the brain. And this will lead to complete recovery of the neurological deficit. So the symptoms and signs which develops due to cerebral ischemia, in transient ischemic attack, it will completely recover within 24 hours. And the brain imaging will show no cerebral infarction. So in order to diagnose someone with TIA, number one, all the symptoms and signs related to the neurological deficit must resolve completely within 24 hours. And number two, brain imaging should be normal. It should not show any cerebral infarction. So that means in order to label the patient with ischemic stroke, you need neurological deficit persisting for more than 24 hours, or you need brain imaging showing cerebral infarction. In some cases, stroke might be asymptomatic. It might be subclinical. But if you detected a new cerebral infarction in the brain imaging, it will be considered as ischemic stroke. So these are basic definitions. I hope it's clear so far. As we said, 80% of stroke cases are ischemic stroke. So we will focus mainly on ischemic stroke. The first thing we need to do, we need to know what are the principal mechanisms by which ischemic stroke can develop. And this is very important because when you talk about prevention of stroke, and as I said previously, the incidence of stroke has declined significantly in developed countries. The reason why it has declined because they are preventing stroke. They are doing too much work in preventing stroke from the beginning, preventive medicine. And in order to prevent stroke, you need to have a good knowledge and a good understanding of the mechanisms which will lead to ischemic stroke. There are multiple mechanisms by which ischemic stroke can develop. We have 6 main mechanisms that we will talk about. Number one, we have large artery disease. And this is the major and the main mechanism associated with ischemic stroke. By large artery disease, we mean atherosclerotic disease, atherosclerosis. We know that atherosclerosis is the big headache, the biggest headache in medicine. It's associated with acute coronary syndromes, myocardial infarctions. It's associated with cerebrovascular disease. It's associated with peripheral vascular disease, among other complications. So in ischemic stroke, a lot of cases are related to atherosclerotic disease, and hence why most of the patients of ischemic stroke tend to be elderly patients, because we know that age is a major risk factor of atherosclerosis. Elderly patients presenting with ischemic stroke, most probably it's due to atherosclerotic disease. So when we talk about the mechanism of large artery disease, here we mean that this type of ischemic stroke is resulting from atherosclerosis. This atherosclerotic disease most commonly tend to be in the extracranial vessels, actually, not in the intracranial vessels. A lot of people might think that the atherosclerosis is affecting the intracranial vessels, like the middle cerebral artery or anterior cerebral artery, and so on. But actually, the majority of large vessel disease associated with ischemic stroke is affecting the extracranial large vessels, like the root, like the arch of the aorta, for example, like the common carotid artery, or even the extracranial part of the internal carotid artery. In these extracranial vessels, there is an element of atherosclerotic disease. And this atherosclerotic disease can be a source of ischemic stroke. How? Because whenever these atheroma, when we talk about atherosclerosis, atherosclerosis is a chronic inflammation that affects the medium and large sized vessels. And in atherosclerosis, there is formation of atheromas or atherosclerotic plaques. And these atheromas usually seen on the extracranial vessels. At any point, if the risk factors of atherosclerosis are not well controlled, at any point, these atheromas might undergo acute disruption. It might become complicated. By acute disruption, I mean that it can undergo erosion or sometimes even fissuring or rupture. And whenever there is an acute disruption of atheroma at any vascular site, this will immediately be followed by thrombosis. There will be thrombosis at the site of the at the site of the disrupted atheroma. And this thrombosis will lead to local occlusion of the vessel. It might not cause a major problem in extracranial vessel due to the diameter of the vessel. But this thrombus and this thrombosis, which will be formed on top of the rupture, on top of the disrupted atheroma, it might embolize. Fragments of the thrombus might detach, might break away, and it might embolize distal part of the circulation. And we know that the anterior circulation, for example, that supply the brain tissue is coming from the internal carotid artery, and the internal carotid artery is coming from the common carotid artery, and so on. So if there is an atheroma which underwent acute disruption in the common carotid artery, for example, this acute disruption can lead to distal embolization of part of the anterior circulation of the brain. The embolus might go on to the anterior circulation. It might, for example, it might occlude the middle cerebral artery, and you will end up with middle cerebral artery territory stroke, ischemic stroke. So here, the original pathology, the primary site of the pathology is not in the intracranial vessel, it's in the extracranial vessel. And this is an example of large artery disease, which is a major mechanism leading to ischemic stroke. In some cases, the large artery disease might be affecting the intracranial vessels. There might be local pathology in one of the intracranial vessels. For example, the internal carotid artery, inside its intracranial course, it might be affected by atherosclerosis, or maybe the middle cerebral artery as well might be affected. So here the atheroma will be formed in one of the intracranial vessels. And in these circumstances, ischemic stroke can also develop, again, due to disruption of the atheroma. But here, when the atheroma becomes disrupted inside the intracranial vessels, it might lead to local thrombosis. So in these types of ischemic stroke, it tends to be thrombotic ischemic stroke, not embolic. When we talked about the extracranial atherosclerotic disease, here the type of ischemic stroke is embolic ischemic stroke. This is due to artery-to-artery embolism. This is called embolic ischemic stroke. But if the atherosclerotic disease is in the intracranial vessels, you can end up with thrombotic ischemic stroke. But also, if the atheroma is affecting a proximal part of the anterior circulation, the thrombus which will be formed in the proximal part of the anterior circulation might lead to distal embolization into the distal part of the anterior circulation. For example, ممكن يكون الأثيروما in the proximal part of the middle cerebral artery or in the internal carotid artery in its intracranial course. And when the atheroma becomes disrupted, thrombus will be formed on top of the disrupted atheroma. Part of this thrombus will form an emboli, and this embolus might occlude distal part of the middle cerebral artery. So here again, you will have embolic ischemic stroke. So in large artery disease, usually the mechanism here is artery-to-artery embolism. This is what we call it, artery-to-artery embolism. But sometimes it can be thrombotic stroke. Actually, in most of the cases of ischemic stroke tend to be embolic stroke rather than thrombotic stroke. So this is one of the mechanisms leading to ischemic stroke, large artery disease, and it's related to atherosclerosis. So in order to prevent these types of stroke resulting from large artery disease, what we need to do is to control and to modify the risk factors of atherosclerosis, because the pathophysiology here is related to atherosclerosis. And we know that atherosclerosis has plenty of risk factors. We have modifiable risk factors and we have non-modifiable risk factors. Modifiable risk factors means the risk factors which can be controlled, which can be modified, which can be reversed, like hypertension, like diabetes, like dyslipidemia, and like smoking. While the non-modifiable risk factors are those risk factors which cannot be modified, like the age of the patient, like family history. And by family history, we mean first degree relative family history. And also the gender of the patient and the sex of the patient. All these are non-modifiable risk factors. When we talk about the gender of the patient as a risk factor of atherosclerosis, we know that males are at more risk of atherosclerotic complications compared to females, but this is not a strict rule. Here we mean that males in comparison to premenopausal females, when we say that males are at more risk of atherosclerotic diseases like MIs and like CVAs, this when you compare, here we mean that this comparison is between males and premenopausal females. And this is due to the protective effect of estrogen in premenopausal females. But in postmenopausal females, the loss of estrogen will put the postmenopausal women at the same risk as males. So males are at higher risk of atherosclerotic complications compared to premenopausal females only, okay? So this is how to prevent ischemic stroke due to secondary to large artery disease. We hunt the risk factors responsible for atherosclerosis. Among these risk factors, the most common risk factor is hypertension. Hypertension is the most common risk factor for atherosclerosis, while diabetes is the most important risk factor. So when you control diabetes, you will get the best results compared to controlling other risk factors. Smoking will give you the immediate or the fastest results. If you encourage someone to quit smoking, and he took your advice and he stopped smoking completely, after 1 year from smoking cessation, his atherosclerotic disease, the risk of atherosclerotic disease will be reduced by 50%. So the risk of developing strokes and developing MIs will be reduced by 50% if he only stopped smoking for just 1 year. This is how important the impact of smoking on atherosclerosis, because atherosclerosis is resulting from anything which can damage and which can harm the vascular endothelium, and nicotine is a harmful substance on the vascular endothelium. So unless you control these risk factors, the patient will be at risk of atherosclerotic complications, including ischemic strokes. So this is an important mechanism. Then let's talk about another mechanism, second mechanism, which is cardioembolism. Here, this mechanism of ischemic stroke, again, is embolic stroke. This is embolic ischemic stroke. But here, the source of embolism is not in the extracranial or intracranial vessels. This is not artery-to-artery embolism. This is heart-to-artery embolism. This is cardioembolism. The source of the embolism is coming from the heart. And here, any form of structural or functional cardiac disease might be considered as a risk factor for this type of ischemic stroke. So think of any structural heart disease. Think of any functional heart condition, and any type of arrhythmia. If it's sustained enough, eventually it can be considered as a risk factor for cardioembolism. The most common cause of cardioembolism overall is atrial fibrillation. This is a general rule. Atrial fibrillation is the most common and the most important cause of cardioembolism. But also there are plenty of other causes. When you talk about structural heart disease, we should think of valvular heart diseases. This is an important cause. For example, rheumatic mitral stenosis. Rheumatic mitral stenosis will lead to left atrial dilatation. Left atrial dilatation itself is a risk for intracardiac thrombus. In cardioembolism, the thrombus inside the heart might be in the left atrium, it might be in the left ventricular wall, or it might be in the apex of the left ventricle. And from there, emboli can arise and it can occlude part of the cerebral circulation. So valvular heart diseases are important cause. Congenital heart diseases, it's an important cause of ischemic stroke, of cardioembolic ischemic stroke. Also cardiomyopathies with its different types. Bacterial endocarditis, vegetations formed on the valve can embolize, can give rise to septic emboli, which can go to the brain and it can occlude part of the cerebral circulation, giving ischemic stroke. Also, these septic emboli can lead to cerebral abscess. And we have also arrhythmias. Arrhythmias are very important source of cardioemboli, and the most important type of arrhythmia and the most common cause of cardioembolic stroke overall is atrial fibrillation, as we said. Then also we should consider and we should think about paradoxical embolism as a possible cause of cardioembolic stroke, especially if you are dealing with relatively young patient presenting with ischemic stroke. Paradoxical embolism can be seen in patients with patent foramen ovale. It can be seen also in patients with atrial septal defect. These are important causes of paradoxical embolism, in which thromboembolism from the venous side can go to the can result in cardioembolic stroke. For example, you can have a patient with history of DVT, and it will be followed with ischemic stroke. And this is due to communication from the venous side and the systemic arterial side. And this is due to left-right shunt which could be secondary to PFO, patent foramen ovale, or it could be secondary to ASD. We'll not go into much details here. This is related to cardiology. Sorry, any question? So we were speaking about cardioembolism. This is another mechanism leading to ischemic stroke. Then the third mechanism associated with ischemic stroke is small vessel disease, which are also called lacunar infarcts. Here, small vessel disease is different than cardioembolic and large artery disease. In large artery disease and in cardioembolic disease, the disease tend to affect the large vessels. But here we are talking about the small vessels of the brain. The small vessels of the brain means the deep penetrating branches of the cerebral vessels, of the cerebral arteries. The cerebral arteries, like the middle cerebral artery or the anterior cerebral artery or posterior cerebral artery, for example, they give rise to two types of branches. They give cortical branches, which will go superficially and supplies the cortical parts of the brain. And it will give rise also to deep penetrating branches. These deep penetrating branches actually will penetrate the cortex, and it will go on deep inside the brain substance. It will go to supply subcortical structures. It will go to supply deep structures within the cerebral hemispheres and deep structures within the brainstem as well. And if there is a disease affecting these small, deep penetrating vessels, it will be called small vessel disease of the brain. And this small vessel disease will give rise to a type of infarcts, type of ischemic strokes called lacunar strokes or lacunar infarcts. Lacunar infarcts is derived from the Latin word lacunae. Lacunes means lakes of water, lake, يعني بركة من الماء, lakes of water. And this is due to the appearance of these infarcts on autopsy. يعني من عملوا autopsy of the brain to patients suffering from lacunar infarcts, they found that these small infarcts resembling lake of waters. This is because in the brain tissue, the type of necrosis, if we went back to basic pathology, the type of necrosis which happened within the brain tissue is liquefactive necrosis. And in liquefactive necrosis, the necrotic material eventually will be, it will transform into a cavity, into a fluid-filled cavity. And this is called lacunes. So when there is small areas of infarction within the brain due to lacunar infarcts or lacunar stroke, eventually these will appear like small cavities. And it can be detected on autopsy. It might appear also on brain imaging as well. For that reason, it's called lacunar infarcts. The pathogenesis of this small vessel disease, it can be related to two main mechanisms. Previously, it was thought that the main mechanism leading to small vessel disease is something called lipohyalinosis of these small vessels. These small vessels will undergo something called lipohyalinosis. Lipohyalinosis is secondary to hypertension. This is similar to the changes of hypertension which happens in hypertensive emergencies, for example. In hypertensive emergencies, the changes which happen in the blood vessels are called also lipohyalinotic changes. And the same changes will also appear in small vessel disease. And for that reason, the most important risk factor of small vessel disease is hypertension. When you have a patient with a small vessel disease, almost always the patient will be hypertensive. Because hypertension, the effect of hypertension on the vascular endothelial lining of these small vessels will lead to something called lipohyalinosis. Because due to vascular endothelial injury secondary to long-standing uncontrolled hypertension, there will be leak of plasma fluids. Some of the plasma components will leak into the vessel wall. It will leak into the walls of these small vessels. And these plasma components or plasma materials, under microscope, it will appear as eosinophilic materials, to appear as pink eosinophilic materials. And for that reason, this is called hyalinosis. Hyalinosis, when you say hyalinosis in pathology, it indicates that there is pinkish eosinophilic material detected. So this is why it's called lipohyalinosis, and it's a result of hypertension. This is the main mechanism causing small vessel disease. But recently they discovered that actually small vessel disease also can be related to atherosclerosis as well. There might be atherosclerotic plaques, atherosclerotic stenosis at the origins of these small vessels. These small vessels at their origins from their from the middle cerebral artery or anterior cerebral artery or the posterior cerebral artery, at their origins, at their orifices, there is atherosclerotic disease, which will result in narrowing of the ostia, narrowing of the openings of these vessels. And this will lead to low flow of blood through these vessels. And eventually this will precipitate small areas of infarctions in the deep brain tissues. In general, there are four main syndromes. There are four main stroke syndromes associated with small vessel disease. We have something called pure motor lacunar stroke. We have pure sensory lacunar stroke. We have something called dysarthria with clumsy hand. And also we have something called ataxic hemiplegia. Ataxic hemiplegia. All these are four types of lacunar strokes. We will talk about them later on when we talk about the clinical features of stroke in general. But for now, remember that small vessel disease is an important, actually, mechanism leading to ischemic stroke. And small vessel disease will lead to small infarcts in the deep subcortical structures of the brain. In a lot of cases, it tends to be asymptomatic. And a lot of patients might actually have multiple lacunar infarcts in multiple areas, and it might be silent. Or they might present with specific clinical features. We will talk about it later on. But here, the most important risk factor for small vessel disease is hypertension, which is associated with lipohyalinosis of the small vessels of the brain. Then the mechanism number 4 is arterial dissection. Arterial dissection is an important mechanism of ischemic stroke, again, also in relatively young patients presenting with a stroke. In elderly patients, typical patients presenting with stroke, we always consider large artery disease and also cardioembolism. But if you have a young patient presenting with ischemic stroke, you should think outside the box. You should think about other possible causes. You should think of paradoxical embolism, for example. You should consider arterial dissection as well. This arterial dissection can affect either the anterior circulation or the posterior circulation. And it affects the large vessels. It can affect the internal carotid artery, or it can affect the vertebral artery. And what happens here, there is a tear. The patient will have a tear in the intimal layer of the blood vessel. And this tear in the intimal layer will allow leakage of blood into the wall of the vessel. And the blood which leaks into the wall of the vessel will create a false lumen. It will create another lumen beside the normal lumen in the blood vessel. It will create a false lumen inside the vessel of the wall. And this false lumen inside the vessel of the wall actually will occlude, it will lead to stenosis of the blood vessel. And along with that, at the site of the intimal tear, there will be also superimposed thrombosis. There will be thrombosis at the site of the intimal tear. And this thrombosis at the site of the intimal tear can be followed by distal embolization, and it can lead to embolic ischemic stroke, as we talked previously. So this is how arterial dissection leads to ischemic stroke. The question is, what are the possible conditions leading to arterial dissection? We said that the main point why we are talking too much about the mechanisms of stroke is in order to prevent stroke. So what are the causes leading to arterial dissection? Actually, sometimes arterial dissection can be due to trivial, can be due to mild or even neglected trauma to the artery. Maybe there is simple trauma to the neck leading to internal carotid artery dissection. Or there might be simple trauma to the back of the head, to the back of the neck, to the posterior part of the neck, leading to vertebral artery dissection. This trauma might be due to some manipulation, for example, during massage. Simple massage of the neck, sometimes, if it was a little bit aggressive, it can precipitate vertebral artery dissection. The trauma even might not be remembered by the patient. The patient might not remember when he was hit in the back of the neck or in the front of the neck. But usually the trauma tends to be mild, but it can be due to severe trauma. There might be some underlying also diseases which can predispose to arterial dissection. Think of collagen vascular diseases, which make the vessel walls weak, like Ehlers-Danlos syndrome, for example. Also like fibromuscular dysplasia. Fibromuscular dysplasia is also associated with renal artery stenosis, if you remember. You have a patient with renal artery stenosis, young patient with renal artery stenosis, we think of fibromuscular dysplasia, while old patient with renal artery stenosis, we think of atherosclerosis, atherosclerotic renal artery stenosis. This fibromuscular dysplasia not only affects the renal vessels, it also affects the neck vessels, it affects the carotid vessels as well. And it can lead to, it can predispose to carotid dissection. So there might be some trauma to the neck leading to arterial dissection, or there might be some underlying disease causing arterial dissection. But actually, it was found that in majority of cases, the underlying cause was unknown. They couldn't find the underlying cause behind arterial dissection. The important point here related to arterial dissection, which can help to differentiate this mechanism from the other mechanisms. In arterial dissection, the stroke means focal neurologic deficit, as we talked previously in the definition. The neurological deficit related to stroke in arterial dissection, it might appear after days, after hours, or even after days from the actual onset of arterial dissection. So the patient actually might have arterial dissection for days before starting to develop stroke. And during this period of time before developing stroke, the patient might be suffering from symptoms related to the dissection. There might be unilateral headache. There might be Horner's syndrome in case of internal carotid artery dissection. In case of vertebral artery dissection, there might be pain in the occipital part. There might be occipital headache. So the patient might be suffering from occipital headache for a few days, and then suddenly the patient will start to develop features of stroke, will start to develop neurologic deficit. So this is the main point which can differentiate arterial dissection from other mechanisms of ischemic stroke. Then mechanism number 5 is generalized hypoperfusion. Here we're talking about generalized hypoperfusion. In ischemic stroke in general, there is focal hypoperfusion. There is a focal area in which there is cessation of blood flow. There is reduction of blood flow to a specific part of the brain. And this leads to cerebral infarction. This is the definition of stroke. But diffuse hypoperfusion of the brain, when the whole brain is hypoperfused, if the condition is transient and short, usually the patient will present with syncopal attacks. But if the condition is sustained and prolonged, the patient can develop serious type of ischemic stroke. And this type of ischemic stroke will be seen, the infarction in this type of ischemic stroke will be seen in parts of the brain called watershed areas, the watershed areas. The watershed areas are the parts of the brain at the ends of the vascular territories. And here, most commonly, the most common site of watershed area is at the parieto-occipital junction, the junction between the parietal and occipital loop. Because at this junction, this watershed area, at this part, the territories of the middle cerebral artery is ending. And at the same time, the posterior cerebral artery, also the territories of posterior cerebral artery is ending at the same time. So at this point, the territories of both middle and posterior cerebral artery at their ends. And for that reason, this is called watershed area. So this part of the brain can be considered as vulnerable part to ischemia. So any form of hypoperfusion can lead to ischemia in this part of the brain more than the rest of the brain. This is similar to in myocardial infarction. When we talk about myocardial infarction, we know that the myocardium, the heart muscle, is divided into layers. We know that there is the subendocardial layer, which is the deepest part of the myocardium, the part of the myocardium adjacent to the endocardium. And we have the middle layer and we have the outer layer, which is called the epicardial layer, which is the layer adjacent to the pericardium. When there is occlusion, when there is coronary artery disease, when there is acute coronary syndrome, the deepest part of the myocardium will suffer first. It will suffer before the more superficial parts of the myocardium, because the deepest part of the myocardium is the last part of the myocardium to receive blood compared to the superficial parts. The blood is coming from outside to inside. And for that reason, the progression of acute coronary syndrome tends to start with subendocardial ischemia initially. And this subendocardial ischemia, clinically, it will present as unstable angina. And then as the condition progresses more minutes, this subendocardial ischemia will be converted into subendocardial infarction. And at this point, the patient will have non-ST elevation myocardial infarction. And as the condition progresses even further, the infarction and the wave of ischemia and infarction will extend more superficially, and it will involve the whole transmural thickness of the myocardium, and you will end up eventually with the ST elevation MI. The same thing here in the brain. In the brain, there are certain parts, there are certain areas which are receiving less blood compared to the rest of the brain. Under normal circumstances, there is no problem. But if there is generalized hypoperfusion, for example, if the patient went into cardiac arrest for any reason, during cardiac arrest, the brain is deprived of blood. It depends on how fast you revive your patient. Maybe after 5 minutes, you were able to revive your patient. The patient recovered. But these critical parts of the brain, the watershed areas, it will not recover. because these areas are very delicate and very sensitive to any short in blood supply. When there is generalized hypoperfusion, this part of the brain will suffer first. These are called watershed area and most commonly at the parieto-occipital junction. This is a type of stroke which develops in postoperative patients. Surgeons always tell their patients when they counsel their patient before any surgery, before any major surgery, they always tell their patient there is a possibility of stroke. It's a small possibility, but it's there. You might be wondering, if you are doing surgery in the abdomen, how come you get a stroke? The reason why during surgery, during major surgeries, the patient might lose tremendous amount of blood, and this large blood volume can lead to hypotension. And if this hypotension is not controlled immediately, the watershed areas in the brain will suffer and it will undergo infarction. So the patient, when he recovers from surgery, they will find out that the patient is having stroke as a complication of an abdominal surgery or any form of major surgery. So this is one of the possible mechanisms of ischemic stroke. I hope it's clear so far. Finally, the last mechanism is venous thrombosis. When we speak about ischemic stroke, in most of the cases, ischemic stroke is due to arterial occlusion. But in minority of the cases, ischemic stroke can be due to venous occlusion as well. And this is called venous thrombosis. We'll not go into details here, but remember that venous thrombosis and venous stroke can be suspected if the patient is having stroke, if the patient is having infarctions in unusual sites. Usually there are specific territories of cerebral blood vessels. And from knowledge, when you have a knowledge about the anatomy of the blood supply of the brain, you will know what are the specific territories supplied by each cerebral artery. If you have an infarction, area of infarction in an unusual site, which might not be linked to a specific artery, you might think here that this is a venous stroke, not an arterial stroke. And in venous stroke, these infarctions usually tend to be hemorrhagic infarction because there is congestion. There is venous stasis and there is congestion in the brain, and this can lead to petechial hemorrhage in the brain, lead to hemorrhagic infarctions. So when you have hemorrhagic infarctions, you can think of venous thrombosis. But remember, hemorrhagic infarctions also can be seen with cardioembolic stroke. And actually, when you compare the different mechanisms of arterial stroke, of ischemic stroke due to arterial disease, the most likely type of ischemic stroke which can lead to hemorrhagic transformation is cardioembolic stroke, not large artery disease. Cardioembolic stroke usually is the most likely type, or most likely mechanism which can lead to hemorrhagic infarctions or hemorrhagic transformation in the infarction. So these are the basic mechanisms which can lead to ischemic stroke. Then there are other uncommon possible mechanisms which can lead to ischemic stroke. And these uncommon mechanisms also should be considered, especially in young patients presenting with stroke. As we said, stroke in a lot of cases is due to embolism, it's embolic stroke. But sometimes there might be thrombotic stroke due to in situ thrombosis. The patient might be a young patient, there are no risk factors of atherosclerosis, and the patient all of a sudden presented with focal neurologic deficit. So you consider a diagnosis of stroke. And on brain imaging, you found that the patient is having cerebral infarction. So it's an ischemic stroke. So you will start looking, you start hunting for the underlying cause. You'll start to think about what is the possible mechanisms leading to ischemic stroke. There is no possibility of atherosclerotic disease because the patient is young, no risk factors for atherosclerosis. You performed all the cardiac examination and investigations, but there were no evidence of structural or functional heart disease, which can explain cardioembolic stroke. The possibility could be in situ thrombosis within the intracranial vessels. There might be thrombosis inside the intracranial vessels, not related to atherosclerosis, without any atherosclerotic plaque. And this could be due to some hypercoagulable states. For example, the patient might be having some inherited thrombophilia, like protein C, protein S, antithrombin 3 deficiencies, or factor 5 mutation. Or there might be some acquired type of hypercoagulable state, acquired cause of hypercoagulable state, like antiphospholipid syndrome. Maybe female patient with a history of recurrent abortion suddenly developed stroke. Here you might think of antiphospholipid syndrome. Also, it could be due to nephrotic syndrome. In nephrotic syndrome, the patient will have hypercoagulable state. Also, in young patients, especially here, you should think of sickle cell anemia, sickle cell disease, which can also is an important cause of stroke in children. Also, you can think of hyperviscosity syndromes, conditions associated with hyperviscosity of the blood, like polycythemia vera, for example, like essential thrombocytosis. Or you can think of vasculitis as well, like systemic lupus erythematosus. So these are unusual, uncommon causes of ischemic stroke, which should be thought whenever you have a patient with, or whenever you have a young patient presenting with a stroke. But these 6 are the main and the major mechanisms associated with ischemic stroke. So having good knowledge about these possible mechanisms, it can help you to prevent ischemic stroke from the beginning. And this is why, in developed countries, the incidence of ischemic stroke is declining, while still here in developing countries, the incidence of stroke actually is rising, it's increasing, because we are not doing a good job in controlling the possible mechanisms leading to stroke. There are patients with persistent atrial fibrillation, with chronic atrial fibrillations, who are not properly anticoagulated. Those patients at any point might develop cardioembolic stroke. There are a lot of elderly patients with diabetes, with hypertension, with poor control. They are also prone to develop large artery disease leading to ischemic stroke, and so on. I hope everything is clear till now.
Yeah, it's clear.
Yeah, it is clear.
Any question related to this section before we jump to the next section? So, after talking about mechanisms associated with ischemic stroke, now let's talk about the clinical findings, the types of neurologic deficits which can be seen in patients with ischemic stroke specifically. Before we talk about these clinical findings, first we need to have some basic knowledge related to the anatomy of the blood supply of the brain. We know that the brain is supplied by 2 systems. We have 2 major systems. We have the anterior circulation and we have the posterior circulation. The anterior circulation of the brain is coming from the internal carotid arteries. We have paired internal carotid arteries, one on each side. Internal carotid artery, as we know, is coming from the common carotid artery, which terminates by dividing into internal and external carotid arteries. The internal carotid artery will enter the cranial cavity, and it will form the anterior circulation of the brain. The internal carotid artery, when it enters the cranial cavity, it will give rise initially to 3 branches. These branches include the ophthalmic artery, and this is a very important branch because it supplies the orbit, it supplies the optic nerve, it supplies the retina. Then also it gives rise to an artery called anterior choroidal artery, and this artery contributes in the formation of CSF. And then it gives rise to a branch called posterior communicating artery. This posterior communicating artery, it's called posterior communicating artery because it will communicate posteriorly with the posterior cerebral artery in order to complete the circle of Willis. The posterior cerebral artery is coming from the posterior circulation, but the internal carotid artery will give rise to a branch called posterior communicating artery, which will connect the posterior cerebral artery with the anterior circulation in order to complete the circle of Willis, as we know. Then after giving rise to these 3 branches, the internal carotid artery will terminate by dividing into anterior and middle cerebral arteries. The middle cerebral artery is the direct continuation of the internal carotid artery, and this is important. Later on, when we talk about the strokes related to internal carotid artery, the patient clinically will present with features of middle cerebral artery occlusion because the internal carotid artery is continuing that the middle cerebral artery is a direct continuation of the internal carotid artery. So this is basically the anterior circulation of the brain. The areas or the territories supplied by the anterior circulation of the brain includes the anterior circulation of the brain will supply the cerebral hemispheres except the occipital lobe. The occipital lobe, posteriorly, it's supplied by the posterior circulation. But the rest of the cerebral hemisphere is supplied by the anterior circulation. Then also the anterior circulation supplies, cerebral arteries will give you cortical branches and deep penetrating branches. A cortical branches will supply a cortex. A deep penetrating branches will supply deep subcortical structures. If we talked in more details about the parts of the brain supplied by the anterior circulation. The middle cerebral artery first. The middle cerebral artery بدينا cortical branches وبدينا deep penetrating branches. The cortical branches of the middle cerebral artery will mainly supply a lateral surface of the cerebral hemisphere. As you can see here in this picture, most of the lateral surface of the cerebral hemisphere is supplied by the middle cerebral artery. This is the main cortical branches of the middle cerebral artery, mainly directed to this part of the cerebral hemisphere. Almost the entire lateral surface of the cerebral hemisphere is supplied by the middle cerebral artery, except 1 inch on the along the superior border, and this 1 inch along the superior border is supplied by the anterior cerebral artery. And this is of clinical importance. We will come to that in a while. And also we have 1 inch along the inferior border of the lateral surface, which is not supplied by the middle cerebral artery, and instead it's supplied by the posterior cerebral artery. So as a general rule, the middle cerebral artery, through its cortical branches, it will supply the lateral surface of the cerebral hemisphere, except 1 inch along the superior border and 1 inch along the inferior border. These are the cortical branches of the MCA, of the middle cerebral artery. The clinical significance of these cortical branches is in the fact that there are important centers located in the areas supplied by the middle cerebral artery. في lateral surface of the cerebral hemisphere, there are important centers which will be supplied by the middle cerebral artery. Here we have sulcus called central sulcus, and in front of this sulcus we have a gyrus here. This gyrus is, at this point, there is the motor cortex. Here we have the motor cortex, the motor center. This part of the cerebral hemisphere will control the movement on the contralateral half of the body. It's called precentral gyrus. And behind this gyrus, we have postcentral gyrus here. And this gyrus is the sensory cortex. This gyrus is responsible for receiving the sensations from the opposite half, from the contralateral half of the body, somatic sensations. And these are important centers which are supplied by the middle cerebral artery. Also here we have an important area in the inferior in the inferior frontal gyrus. It's called Broca area. This area is concerned with language. And here also we have another important area in the posterior part of the superior temporal gyrus. This is called superior temporal gyrus. At the posterior part of this superior temporal gyrus, and in the areas of the parietal lobe adjacent to this part, in this area we have an important language center called Vernix area. Vernix area. So here we have Broca's area, and here we have Vernix area, and these are two important language centers, and both are supplied by the middle cerebral artery, and this is of clinical significance. So these are important cortical sites or cortical centers which will be supplied by the middle cerebral artery. And these are the cortical branches of the middle cerebral artery. Then, as we said, along with the cortical branches, also the middle cerebral artery will give us deep penetrating branches. And these deep penetrating branches will penetrate the cortex, and it will go deep in the cerebrum, and it will supply subcortical structures. The important structures supplied by the deep branches of the middle cerebral artery are the internal capsule and the basal ganglia. If you need to remember two areas, two important parts supplied by the deep branches of the middle cerebral artery, remember the internal capsule and the basal ganglia. So these are simply territories supplied by the middle cerebral artery. Then when we talk about the anterior cerebral artery, an anterior cerebral artery will supply a medial surface of the cerebral hemisphere. And middle cerebral artery بدينا lateral surface, لكن anterior cerebral artery through its cortical branches will supply mainly the medial surface of the cerebral hemisphere. As you can see here, this is medial view. This is medial view, and it's mainly supplied by the anterior cerebral artery. And this is very important, it has a clinical significance, also we will talk about it. And along with the medial surface, it will supply the lateral surface on its upper border, on the upper 1 inch, the upper 1 inch along the superior border of the lateral surface, which is not supplied by the middle cerebral artery, as we said previously. It will be supplied by the anterior cerebral artery. So the anterior cerebral artery mainly supplies the medial surface, but also it gives blood supply to a small part of the lateral surface. These are the cortical branches of the anterior cerebral artery. The deep branches of the anterior cerebral artery will supply mainly the corpus callosum. Corpus callosum, which is commissural fibers that connects the two cerebral hemispheres together. It's mainly supplied by the anterior cerebral artery, except the posterior end of the corpus callosum, which is called the splenium. The splenium part of the corpus callosum is not supplied by the anterior cerebral artery. Because it's located posteriorly, it will be supplied by the posterior cerebral artery. And this is very important because if there is a stroke affecting the anterior cerebral artery and it affected the area in the corpus callosum, which is supplied by the anterior cerebral artery, it can give you special types of neurologic deficit. And it will give you a condition called disconnection syndrome, because you disconnected the right hemisphere from the left hemisphere. Because the corpus callosum is a commissural fibers. The commissural fibers in the brain, it's a type of white matter. It's part of the white matter of the brain, which connects the right hemisphere with the left hemisphere. So these are the important parts supplied by the anterior cerebral artery. So this is the anterior circulation. So here we talked about the anterior circulation. And anterior circulation means internal carotid artery. Eventually it will end with the middle cerebral artery and anterior cerebral artery. So we would like to know what are the types of neurological deficits which can develop due to anterior circulation stroke. If you have a stroke within some point of the anterior circulation, for example, a stroke affecting the middle cerebral artery, or affecting the anterior cerebral artery, or affecting even the internal carotid artery, what will be the types of neurologic deficits which will be developed? And how we can link it with the anatomy, how we can link it with our knowledge about the centers of the brain. And from there, we can know which artery affected, we can know where is the exact site of the lesion. So first, we will talk about the middle cerebral artery. The middle cerebral artery stroke. If you have a stroke within the middle cerebral artery territory, what will be the types of neurologic deficits? In order to understand these neurologic deficits resulting from middle cerebral artery occlusion, first we need to know the course of the middle cerebral artery, anatomically speaking. As you can see here, in this section of the brain, this is the internal carotid artery. I hope the mouse is clear. I'm not sure if it's clear in the, slides. Okay.
Clear.
Okay, this is the internal carotid artery, as you can see it. The internal carotid artery, as we said, will terminate by dividing into middle and anterior cerebral arteries. The middle cerebral artery, remember, it supplies mainly the lateral surface. So when it arises from the internal carotid artery, it should go laterally because it intended to supply the lateral surface. So this is the middle cerebral artery. It will go laterally. As you can see, it will go laterally until it will emerge on the lateral side from this area. This area is called the Sylvian fissure, which is also called lateral sulcus. This lateral sulcus is an important anatomical landmark in the brain, in the cerebral hemisphere, because it separates the frontal and parietal lobe from the temporal lobe. It's called the lateral sulcus. At the level of the lateral sulcus, the middle cerebral artery will emerge on the lateral surface, and it will start to supply the lateral surface of the brain, of the cerebral hemisphere. But let's see first, before it reaches the lateral surface, this proximal part of the middle cerebral artery, you can see it here. The proximal part of the middle cerebral artery is called M1. The proximal segment of the middle cerebral artery is called M1. This is a very important point. You need to focus here. This M1 will give you the deep penetrating branches. As we said, in the cerebral artery, عنده cortical branches, عنده deep penetrating branches. دائما الcerebral arteries سواء middle او anterior او posterior بتدينا الديب penetrating arteries اول، حتى بعدين بتمشي لقدام بتدي الكورتيكال arteries، لانه هي الارتريز دي تبدا دائما من البيس اوف ذا برين، تطلع من البيس اوف ذا برين لحد ما تطلع تمشي على السيرفيس، تمشي على الكورتكس. ف it makes sense انه to give rise to the deep penetrating branches first. So here the M1 segment of the middle cerebral artery will give rise to the deep penetrating branches, as you can see it here. These deep penetrating branches, remember I said that the deep branches of the middle cerebral artery will supply the internal capsule and the basal ganglia. These deep branches are called lenticulostriate arteries. Lenticulostriate arteries. Why do we call it lenticulostriate arteries? Lenticulo is coming from the lenticular nucleus, the lentiform nucleus. Lenticular nucleus is part of the basal ganglia, and we said that deep branches will supply the basal ganglia. Striate is coming from the corpus striatum, which is also part of the basal ganglia. So the name is actually driven from the areas which will be supplied by these branches, because these branches will supply the basal ganglia, And what is adjacent to the basal ganglia? We have the internal capsule. These branches are very important because they supply the internal capsule and the basal ganglia. And these branches will arise from the M1 segment of the middle cerebral artery. Then, after giving rise to the deep lenticulostriate branches, the middle cerebral artery will continue, and it will appear. It will emerge from the lateral sulcus, as we said here on the lateral surface, and at this point, it will give rise to the cortical branches, because at this point, it's on the lateral surface where it will supply the lateral surface of the cerebral hemisphere, as we said, through the cortical branches. The cortical, this part, the distal part, this distal part of the middle cerebral artery is called M2 segment. So the part of the middle cerebral artery which will give rise to the lenticulostriate branches is called M1. After giving rise to the lenticulostriate branches, the rest of the middle cerebral artery is called M2. Okay, this point, I hope this point is clear. This M2 segment is the segment which will give rise to the cortical branches, which will supply the lateral surface of the cerebral hemisphere. And these cortical branches, this M2 segment will give initially rise to two main branches, will give rise to two main divisions. Here, as you can see, this is the middle cerebral artery appearing here on the lateral sulcus. This M2 segment of the middle cerebral artery. This M2 segment of the middle cerebral artery will give you immediately two divisions. There is one division will go superiorly, it's called superior division. And there is another division will go inferiorly, and it's called inferior division. I hope it's clear on the picture. This is the superior division, and this is the inferior division. These divisions will eventually supply the lateral surface of the cerebral hemisphere, as we know. The superior division, because it goes superiorly, it will supply the frontal lobe and the superior half of the parietal lobe. While the inferior division, because it goes inferiorly, it will supply the temporal lobe and the inferior half of the parietal lobe. But it will not supply the occipital because it's supplied by the posterior cerebral artery, as we said. Like, this is of clinical importance. So I hope it's clear until now. بعد ذاك السuperior division بتدينا further branches which will supply different parts of the frontal lobe and parietal lobe. والinferior division تدينا further branches تتفرع زيادة تدينا supply the temporal lobe والinferior part of the parietal lobe. Until here, are we clear?
ايوه واضح.
تمام. اوكي. طيب عايزين نشوف بعد ذاك neurologic deficits which can develop due to involvement of the middle cerebral artery. It will depend on two things. It will depend on the level of occlusion. At which part of the middle cerebral artery there is occlusion. يعني هل في M1 segment ولا M2 segment? Basically. Number two, it will depend on the state of the collateral vessels, the collateral system of the brain. We know that in the brain tissue, actually, we have primary collateral system and we have secondary collateral system. The primary collateral system هو السيركل اوف ويلس. لكنه ما فيدنا كثير هنا at this point في الميدل cerebral artery. ممكن يفيدنا اكثر لما يكون في occlusion في الانترنال carotid artery. وفي secondary collateral system. السكندري collateral system ده بيسموه leptomeningeal vessels or leptomeningeal arteries. This leptomeningeal network or leptomeningeal network of vessels, it will بتعمل لنا communication between the anterior والmiddle والposterior cerebral arteries. فبالتالي these collaterals play an important role in minimizing and limiting the extent of the infarction in patients with ischemic stroke. والحقيقة دي حكمة إلهية، يعني لو ما كانت collaterals دي موجودة يعني any type of strokes will become devastating. It will be massive. لكن there are a lot of patients, although in occlusion ممكن يكون proximal, لكن يكون the size of the infarct يكون limited. And this is due to good state of collaterals. Like, unfortunately, there are patients in which the condition of the collaterals tend to be poor, maybe due to some anatomical abnormality, أصلاً congenital, أو ممكن يكون due to some vascular disease, atherosclerosis affecting the vessels. فبالتالي the condition of the collaterals is not good. And those patients with poor collateralization are at risk to develop larger extent of infarction. These are the two main points which will determine the type of neurologic deficit which will develop. Which part occluded and the state of the collaterals. طيب, let's suppose you have a patient with occlusion of the proximal part of the middle cerebral artery. Here, occlusion of M1, the proximal part of the middle cerebral artery. Before even giving rise to the deep branches. And even, of course, before giving rise to the cortical branches, the annular occlusion is proximal. What will happen here? In this situation, if the collaterals are good, the condition might be mild, actually. Surprisingly, and despite annular occlusion is proximal, if the patient is having good collateral system, the condition tend to be mild. Lakin the problem is, when there is poor collateral system, and this is common actually, especially in elderly patient. If there is poor collateralization and there is proximal occlusion of the middle cerebral artery, the clinical features will be related to, the neurologic deficit will be related to ischemia affecting all the territories supplied by the middle cerebral artery. Annular occlusion is proximal. And you should think first of the internal capsule here. In the internal capsule, we know that the internal capsule is a bundle of fibers, bundle of projection fibers. في neuroanatomy, white matter of the brain بيقسموها لفور types. عندنا الكوميشورال fibers, عندنا منها projection fibers. The projection fibers, these are the ascending and descending fibers in the brain tissue, in the white matter of the brain. في ascending fibers جايه من lower centers ماشيه ل higher centers. For example, a sensory fibers شايل السنسيشن من contralateral half of the body، شايل البين والتمبريتشر and so on، وموديها للsensory cortex في البرايتال loop. This is a part of the projection fibers, and it will pass through the internal capsule. We have also the optic and auditory radiation. They're part of the ascending projection fibers, and it will go on to the visual center and to the auditory center in the temporal loop, visual center في occipital loop. All these fibers will ascend through the internal capsule. And we have descending fibers as well. And these are important descending fibers. اللي بنعرفها هي pyramidal fibers. اللي هي fibers which will control the movement on the contralateral half of the body. So all these descending and ascending fibers will be bundled together in an area called internal capsule. يعني بتكون كلها متجمعة في حتة اسمها internal capsule. فإذا internal capsule, if there is a small lesion, there is a pathology in the internal capsule, whatever this nature of pathology, ممكن يكون vascular, ممكن يكون tumor, for example, this pathology will damage all the fibers. لأنه internal capsule, the fibers كلها bundled together in a narrow area. So the patient will have neurologic deficit due to involvement of كل fibers in the internal capsule. So if there is ischemia in this part of the brain due to proximal occlusion of the middle cerebral artery, what happens is the patient will have contralateral hemiplegia, right? Because كل التراكس, pyramidal tracts النازلة to supply the contralateral half of the body from من فوق لتحت, it will be affected. So there will be weakness affecting both the upper limbs and lower limbs symmetrically. And this is called dense hemiplegia. والweakness دائما بيكون severe لأنه كل الفايبرز متجمعة في حتة ضيقة. So usually patient can present with severe hemiplegia, not hemiparesis. The grade of the power of the muscles might be 0 on presentation. There is contralateral hemiplegia. Along with that, also there is contralateral hemianesthesia. The same thing, the ascending fibers carrying sensations will be affected, and this will lead to loss of all modalities of sensation on the contralateral half of the body. This is called contralateral hemianesthesia or contralateral sensory loss. Okay, it's affecting the upper and lower limbs symmetrically. لأنه في internal capsule الفايبرز كلها بتاعت الupper والlower limbs located closely to each other. لكن لما نتكلم بعد ذاك عن الباثولوجي في الكورتكس في الكورتيكال انفاركشنز، الupper limbs area بتكون inferiorly والlower limbs area بتكون superiorly on the cerebral hemisphere. فبالتالي you can have weakness affecting the upper limbs more than the lower limbs, or weakness affecting the lower limbs more than the upper limbs. لكن when we speak about capsular infarction, the weakness will be symmetrical. The sensory loss also will be symmetrical on the upper and lower limbs. So لما نتكلم عن البروكسيمال middle cerebral artery occlusion، أول حاجة بيكون في contralateral hemiplegia, dense hemiplegia, contralateral hemianesthesia. Also, the facial nerve fibers will be affected. The upper motor neuron fibers of the facial nerve will be affected. So you will have also contralateral upper motor neuron facial weakness or facial palsy. Along with that, also a visual radiation. احنا قلنا كل الفايبرز ascending or descending. Not only a sensory fibers الطالع, also a visual radiation will be affected. The visual radiation, which is supposed to go to the occipital lobe, will be affected, and this will give you visual field defect, which is called homonymous hemianopia. You will have contralateral homonymous hemianopia. There will be problem with the visual field. Again, associated with proximal MCA occlusion. كل الcollection of features دي actually is due to involvement of the internal capsule. يعني نحن لسه still we didn't talk about the cortical branches لكن هنا occlusion because the occlusion is proximal in M1 in the proximal part of the MCA. First, deep parts of the brain supplied by the MCA will be affected. And along with that also the cortical parts of the brain supplied by the MCA as well will be affected. And the patient will have cortical neurologic findings. Like what? Remember we said that في الرسمة هنا في important centers on the lateral surface supplied by the midcerebral artery. قلنا في language areas. Here في frontal lobe وفي temporal lobe. Here we have Broca's area, here we have Wernicke's area. If the occlusion is proximal, معناتها both language areas will be affected. يعني in general في neurology إذا pathology كان في Broca area only, you will have Broca aphasia. Broca aphasia also called non-fluent aphasia, which is also called expressive aphasia. عندها كم اسم؟ Expressive aphasia, non-fluent aphasia, Broca aphasia. دي كلها implying إنه lesion here in the Broca area. يسمى area 44. أما يكون lesion في Wernicke's area, you will have Wernicke's aphasia, which is also called fluent aphasia, which is also called receptive aphasia, عكس البروكا aphasia. ده لكن إذا كان lesion or pathology localized here or here. لكن if you have an occlusion في proximal part of the middle cerebral artery من هنا, you think the pathology or ischemia will be localized to here or here? No, it will affect both language centers, and it will even affect the fibers which connect the language centers together. And these language centers are under communication. They are communicating in order for you to speak fluently with good language. You need good communication between the Broca and Wernicke's area. There are fibers which connect these two areas, and these are called arcuate fibers. And these are part of the white matter of the brain. So these fibers also will be affected if you have a proximal occlusion of the MCA, because all these fibers are also part of the territory supplied by the MCA. So for that reason, the type of aphasia which will develop in patients with proximal occlusion of the MCA, it will be global aphasia. When we say global aphasia, it means this is a type of aphasia which include both Broca and Wernicke's at the same time. You have features of both Broca and Wernicke's because both areas are affected. This is called global aphasia. So this is what happens if you have proximal middle cerebral artery occlusion. This is part of the cortical neurologic deficit. طيب, another cortical neurologic deficit, طبعا الaphasia would not develop in any patient with proximal MCA occlusion, because in order to have aphasia, the dominant hemisphere must be affected. Actually, the dominant hemisphere usually the left hemisphere. لكن if you have مثلا stroke affecting the right middle cerebral artery, هنا sometimes ممكن ما يكون في aphasia لأنه الaphasia language centers موجودة في dominant hemisphere. طيب, the question is, if you have an ischemia, middle cerebral artery occlusion, territory stroke in the non-dominant hemisphere, what will be the type of neurological deficit instead of aphasia? If the patient is not having aphasia, what will be the clinical features? What will be the neurological findings which will develop? In the non-dominant hemisphere, the patient can have something called hemi-neglect, which is also called asomatognosia. What do we mean by hemi-neglect? Hemi-neglect, simply the patient will neglect half of his body. Yani patient will not consider that he has a left limb. Will not consider he has a left arm and left leg. The patient will totally neglect half of his body. That's why it's called asomatognosia, because here the middle cerebral artery supply the parietal lobe, and in the parietal lobe we have the sensory centers in the parietal lobe, which receives and perceive, and it's responsible for interpretation of the proprioceptive sensations, the sensations which are coming from the joints, sensation of joint position, sensation of movement, sensation of vibration, all will be collected in the parietal lobe. When there is ischemia affecting the parietal lobe, specifically the non-dominant hemisphere, the patient will have problem related. The patient will have hemi-neglect, which is also called asomatognosia. You can test for asomatognosia or hemi-neglect simply by giving the patient a piece of paper and ask him to draw a clock. تخلوه يرسم ساعة بأرقام الساعة، هو من 12 فوق لحد 0 12 6 تحت، يعني يرسم الساعه بالارقام كلها بتاعتها. In patient with hemineglect they will draw the clock on 1/2، يعني من 12 لحد نهايه الساعه كلها بتكون في جانب واحد، في الجانب اليمين، والجانب الشمال تلقاه empty. This is because the patient is neglecting the left visual field, the left half of his body. If you gave the patient something on his left hand, he will grab it with his right hand, not with his left hand, because he thinks that he has no left hand. He has only one side. This type of neurologic deficit is seen in patients who are having usually proximal occlusion of the MCA and affecting the non-dominant hemisphere. طيب, along with the hemineglect, also there are other neurological findings. There is something called anosognosia. Anosognosia, this is simply called lack of insight. Yani the patient will not think that he's sick. Yani this patient, his family will bring the patient to the hospital. The patient will not think that he has a neurological deficit. He will not think that he has a hemiplegia. He will not think that he has hemisensory loss. He will think that he's completely normal. He's completely okay. This is called lack of insight. Yani the patient ما عنده insight about his illness. This is similar to what happens in patients with Alzheimer's disease, patients with dementia. الناس Alzheimer's ما في زول عنده Alzheimer يعني طبعا بيجي براه to seek medical advice. His family will bring him to the doctor. When you ask the patient will tell you that there's nothing wrong with me. I keep telling my family that I'm perfectly fine. There's nothing wrong with me, and they keep insisting that I have problem with memory. I have problem with a lot of things. This is called anosognosia, lack of insight. It's a main feature. It's a common feature in patients with Alzheimer and patients with dementias. But it can be seen also due to stroke. In stroke, it can be seen with middle cerebral artery occlusion, affecting the non-dominant hemisphere. يبقى non-dominant hemisphere بدينا hemineglect, بدينا anosognosia. And number 3 also, a third feature ممكن تجي مع non-dominant hemisphere is apraxia. Apraxia means difficulty in performing pre-learned motor tasks or motor skills. يعني في motor skills the patient كان بيعرف يعملها before the onset of stroke. فجأة after stroke the patient will be unable to perform these motor skills, despite إنه ممكن ما يكون في true weakness in the muscles. يعني these motor skills can be done مثلا with the right hand ويكون ال weakness في left. يعني the right hand ما فيها issue, لكن still the patient cannot do it. And here the problem is not due to weakness in the muscle. The muscles power are intact ممكن تكون. The problem is not related to the motor system. Here the problem is related to planning of the movement. The patient, the execution of the movement, تنفيذ الموفمنت نفسه is intact. The muscles are intact. لكن the planning or programming of the movement in the cerebral cortex, specifically in the frontal association area, is impaired. Because these areas are supplied by the middle cerebral artery. فبالتالي مثلا if you ask the patient to draw 5-pointed star، يعني تقول ارسم نجمه عاديه في الورقه، ما هيقدر يرسمها بطريقه صح. This is called constructional apraxia. It's also seen in patients with hepatic encephalopathy. Or مثلا patient might be having difficulty in tying his shoe. يعني تقول له simply يحاول اربط الرباط على الجزمه، يكون كان بيعرف يربط الجزمه عادي لكن يبقى ما بيقدر يربط الجزمه. This is why children cannot tie their own shoes because still يعني عندهم مشكله في planning and programming of the movement, not like adults. ما يقدر مثلا there might be problem or difficulty in doing up البوتنز، يعني لما يجي يحاول يزرر الزراير بتاعت القميص ما يقدر. هنا المشكله ما في المصل نفسها is power is good. When you do examination of the power you might have even grade 5 power, but the problem is in the planning and programming of the movement. This is called apraxia, and it can be seen due to middle cerebral artery occlusion, proximal MCA occlusion, affecting the non-dominant hemisphere of the brain. I hope it's clear. يعني احنا لما نتكلم عن الميدل cerebral artery occlusion عرفنا الفيتشرز related to involvement of the internal capsule. الكورتيكال features بتحدد لنا whether the dominant or non-dominant hemisphere is affected. دائما بيكون dominant affected. هنا patient will present with aphasia. وإذا كان proximal occlusion هنا يكون global aphasia. لكن if the non-dominant hemisphere is the one that is affected, you will not have aphasia. You will have hemineglect. You can have anosognosia. You can have also apraxia. دي كلها cortical neurologic deficit. Finally, في another important cortical neurological deficit related to special area here. There is a special area here. This area is called frontal eye field. Frontal eye field area. It's located in the posterior part of the middle frontal gyrus. The frontal eye field area is responsible for the conjugate eye movement, responsible for the horizontal eye movement. يعني انت واحد لما يكون بيقرا في جريده او في كتاب you move your eye from the left to the right to follow the lines. Am I right? You move your eyes from the left to the right. This symmetrical movement of both eyes horizontally is mediated and is controlled by this area, which is called frontal eye field area. It's it's represented in both cerebral hemispheres. So what will happen if there is an ischemia or infarction affecting this part of the brain? This part of the brain is supplied by the middle cerebral artery. So neurologic deficit related to frontal eye field areas, it will be due to occlusion of the middle cerebral artery. It will not be due to anterior cerebral artery occlusion because these parts are supplied by the MCA. The clinical features, when there is an infarction affecting the frontal eye field, the eyes will be deviated to the ipsilateral side. Both eyes will be deviated to the ipsilateral side. And if the patient is having an infarction affecting the left hemisphere, affecting the frontal eye fields on the left side, both eyes will be deviated towards the left side, towards the ipsilateral side of the lesion. And it's like your eyes, it's like the eyes of the patient are telling you that the site of the pathology is here. The eyes are moving and are directed towards the site of the pathology. This is called conjugate eye movement. يبقى هنا في شنو؟ هنا لما يكون في pathology in the frontal eye fields, you will have gaze preference towards the ipsilateral side. Gaze preference towards the ipsilateral side. يعني the gaze of the eye, the conjugate gaze will prefer the ipsilateral side. It will deviate towards the ipsilateral side. Well, this is some clinical finding which can help you to localize the lesion. You can know the lesion is on the left side. لما يكون الdivision of the eye بيكون towards the ipsilateral side. And it's one of the neurologic deficits which can be seen with middle cerebral artery occlusion. Here we talked about stroke if it's due to occlusion of the proximal part of the middle cerebral artery. This type of stroke is called complete middle cerebral artery syndrome. Complete middle cerebral artery syndrome. لأن المشكلة is affecting the middle cerebral artery completely. It's affecting all the territories supplied by the middle cerebral artery. بنسأل سؤال نقول why نحن عندنا a lot of patients presenting with this type of stroke? Simply because if there are good collaterals, this complete syndrome will not it will be mild. ما هنلقى كل الفيتشرز دي، نلقى some of these features. لما يكون في good collaterals. لكن the problem is if the patient is having poor collaterals. If there are poor collaterals, you can detect all these features at the same time. You can have the patient with hemiplegia, with contralateral hemiplegia, with hemisensory loss, and at the same time his eyes are deviated towards the ipsilateral side, towards the site of the lesion. At the same time, the patient is aphasic. This is called complete middle cerebral artery syndrome. It means that hemiplegia is affecting both upper and lower limbs symmetrically. So that means this is complete middle cerebral artery syndrome. And the prognosis here is poor. You will have large area of infarction in the brain. And sometimes it will lead to something called malignant MCA syndrome. Because here, when there is large volume of infarction, it will be associated with massive cerebral edema. And this massive cerebral edema will increase the intracranial pressure, and it can eventually lead to brain herniation. So these are the types of patients with a stroke who can die rapidly from brain herniation. And a large infarction will increase the intracranial pressure, and it will lead to brain herniation. And here, the infarction will mimic hemorrhage. And even initially, when the patient presents to you, you might think this is hemorrhagic stroke because the presentation is aggressive. That's why it's called malignant MCA. But actually, it's ischemic stroke. And for that reason, as I said previously, it's important to do brain imaging in order to differentiate between ischemic and hemorrhagic stroke. Clinically, you cannot tell 100% whether this is ischemic or hemorrhagic stroke. And there is a big risk if you treated the patient as ischemic stroke and it turned out later that the patient is having hemorrhagic stroke. So always get an imaging, get a brain CT before considering whether this is ischemic or hemorrhagic stroke. because ischemic stroke, large ischemic strokes can act like hemorrhage, can present like hemorrhagic stroke clinically, and sometimes small hemorrhagic strokes can present like ischemic stroke. So it's a little bit tricky sometimes. يمكن لحد هسه احنا we talked about يعني occlusion في proximal part of the middle cerebral artery which is called M1. طيب what about if there is occlusion in the distal part of the middle cerebral artery؟ يعني occlusion after the origin of the lenticulostriate. يعني حصل occlusion in the middle cerebral artery بعد ما طلعت lenticulostriate branches. In these patients, the internal capsule will be intact. So the problem will be in the cortex. It will be in the cortical areas supplied by the middle cerebral artery. So what will be the clinical presentation? The clinical presentation will depend بعد ذلك whether الاوكلوجن مثلا في ممكن يكون الاوكلوجن هنا في الام 2 before giving rise to the superior or inferior divisions. ممكن يكون الاوكلوجن في superior division. ممكن يكون الاوكلوجن في inferior division as we said previously. or even الاوكلوجن ممكن يكون more distal يعني يكون في single branch طالع من superior division او في single branch طالع من inferior division. الفكره هي انه هنا هيكون عندنا partial MCA syndromes. هناك كان عندنا complete. اما الاوكلوجن كان هنا كان complete. Here you will have partial syndromes. اما يكون الاوكلوجن distal to the origin of the lenticulostriate يعني الاوكلوجن في M2 ما في M1 you will have partial syndromes. For example, the patient might only have monoparesis affecting the upper limb. يعني ممكن يكون الاوكلوجن only in that single branch which supply the motor area of the upper limbs. So the patient might present with contralateral weakness in the hand only, or contralateral weakness in the arm and hand, in the entire upper limb. لكن اللور limb يكون intact. لأنه الارتري affected هو single branch. This is called brachial syndrome. Brachial syndrome is one of the partial MCA syndromes when it affects only the upper limb. ما بيكون في any other neurologic deficit. Sometimes ممكن يكون في involvement of the upper limbs و at the same time في معها aphasia. Because as you know from the anatomy, here, the motor area is here, the upper limb motor area is here inferiorly, a language, the Broca area here is adjacent to the to the motor area of the upper limbs. فممكن يكون في involvement of a branch which is supposed to supply كل الarea دي. So the patient will have contralateral upper limb weakness ومعاها يكون في Broca aphasia at the same time. This is another partial syndrome called frontal opercular syndrome. Frontal opercular syndrome. It's called frontal opercular syndrome لأنه opercular جاية من opercular part جاية من opercula. Opercula, this is the part of the cerebral cortex which covers the insula. احنا عارفين إنه هنا في lateral sulcus هنا ده lateral sulcus ده if we separated the lips of the lateral sulcus كده في الأوتوبسي تحت اللاترال سالكس في الفلور اوف ذا لاترال سالكس بنلقى فيه mass of white matter زي كانه في small loop, and this mass of white matter buried within the lateral sulcus is called the insula. الانسولا دي البارت اوف ذا cerebral cortex المغطيها برا دي بسموه opercula, وهي الحته اريا دي. ودي اريا بيحصل فيها يعني sometimes infarction لما يكون في distal occlusion of the middle cerebral artery, one of the partial syndromes. هنا البيشنت will only have upper limb weakness contralateral with Broca aphasia. هنا ما global aphasia, لاحظوا Broca aphasia only لأنه the pathology is limited. فالفيرنيك area بعيدة. This is called frontal opercular syndrome. Anyway, this is one of the partial syndromes. Sometimes ممكن السوبيريور division كله يكون occluded. احنا قلنا الام 2 بيدينا superior و inferior division. ممكن السوبيريور division ده كله يكون occluded. السوبيريور division قلنا normally it should supply الفرونتال لوب كلها والسوبيريور part of the parietal loop. يعني الموتور اريا هنا الموتور اريا والسنسوري ارياس والبروكا اريا والفرونتال اي فيلد دي كلها supplied by the superior division actually. فاذا حصل occlusion في superior division this will give you also partial syndrome. Here the patient will have contralateral hemiparesis, not hemiplegia. Hemiparesis لأنه شنو الموتور area affected. لكن it will be hemiparesis because it will affect the upper limbs more than the lower limbs. يعني تلقى upper limbs the weakness is worse than the weakness in the lower limbs. مثلا تلقى power في upper limbs is grade 1 والpower في lower limbs grade 4 or grade 3. So that means the weakness is worse on the upper limbs compared to the lower limbs. وده الكلام اللي بيكون دايما موجود في السيناريوز بتاعت الام سي اي اوكلوجن. يقول لك MCA occlusion او MCA stroke will give you contralateral hemiparesis, upper limbs more than the lower limbs, يعني affecting the upper limbs more than the lower limbs. This will not happen in any case of MCA stroke. It will happen only if you have a partial syndrome, يعني there is occlusion, distal occlusion of the MCA, يعني in the M2 segment of the MCA. Specifically when there is occlusion of the superior division of M2, superior division of the middle cerebral artery. يعني superior division هو المفروض to supply كل الارياز دي، فبالتالي بيدينا weakness، contralateral weakness يكون more on the upper limbs than the lower limbs. ومعاه طبعا المفروض يكون برضه في شنو؟ بروكا افيزيا اذا كان dominant hemisphere affected. If the dominant hemisphere is not affected, you will not find broca aphasia. There might be also an involvement of the frontal eye field here. As you can see, this circle indicates frontal eye field, and this also will lead to impairment of the conjugate gaze. The eyes will be deviated towards the ipsilateral side of the lesion. يعني بتلقى weakness on one side والeyes are deviated to the opposite side. لأنه الeyes weakness دائما بيكون contralateral to the side of the lesion. لكن eyes deviation بيكون ipsilateral to the side of the lesion. So the scenario للزول اللي عنده superior division هنا ممكن يكون في weakness contralateral weakness affecting the upper limbs more than the lower limbs، ويكون في eye deviation to the opposite side اللي هو towards the side of the lesion. في حالة superior division is occluded. If the inferior division is occluded, an inferior division لاحظوا إنه supplying a temporal loop و supplying an inferior half of the parietal loop. أهم حتة في الارياز شنو هي vernix area here. الvernix area يبقى supplied by the inferior division. فإذا عندنا partial syndrome affecting an inferior division, here your patient can present only with vernix aphasia. إذا كانت dominant hemisphere affected. يعني ممكن ما يكون في weakness totally. Only with vernix aphasia. إذا كانت dominant hemisphere affected. If the non-dominant hemisphere is affected, there will be no vernix aphasia, and instead you will have the three features اللي اتكلمنا عنها، الهيمينيجلكت والانوزوينوزيا والإبراكسيا. لأنه all these areas are supplied by the inferior division. I hope it's clear. It's all about at which point of the middle cerebral artery there is occlusion. It depends on the collateral state. Remember, MCA occlusion ممكن تديك hemiparesis affecting the upper limbs more than the lower limbs. ده في partial syndromes. وممكن تدينا dense hemiplegia affecting the upper وال lower limbs symmetrically equally. وده بيحصل دايما مع الكومبليت MCA occlusion لما يكون في involvement of lenticulostriate branches. I hope it's clear لحد هسه. Any question?
No, it is clear.
والله very clear. فتح الله عليك.
Okay, thank you. هنا this is a simple يعني text يعني revising كلام اللي قلناه كله. Middle cerebral artery territory stroke ممكن تدينا contralateral weakness worse in upper limbs in cortical infarcts. يعني احنا بنتكلم عن لما يكون ال involvement is distal as we said. ممكن يكون dense hemiplegia in proximal MCA occlusion. ممكن يكون في facial weakness upper motor neuron facial weakness of course. contralateral sensory loss. الكونترالاترال sensory loss برضه هنا معلش لما اتكلمنا برضه عن الديستال. في الديستال لما يكون في weakness affecting upper limbs more than the lower limbs برضه بيكون معاه hemisensory loss more on the upper limbs. يعني يكون في sensory loss في upper limbs اكثر او واضح اكثر من انه في lower limbs. This is part of the partial syndromes as well. homonymous hemanopia اللي هي visual field defect دي بنلقاها الهومونيموس هيمانوبيا بنلقاها مع البروكسيمال لما يكون في involvement of the visual او optic radiation في الانترنال كابسول you will have contralateral homonymous هيمانوبيا. ده في لما يكون مشكله بروكسيمال. لكن اذا كان مشكله ديستال مشكله يعني affecting the cortical branches you will not have homonymous هيمانوبيا تحديدا you will have homonymous quadrant anopia. يعني ما كل الهالف of the visual field بيكون affected بيكون الربع بس quadrant anopia. وده ايضا ده برضه بوريك انه الفكره هي شنو الفكره انه الفايبرز او السنترز في السريبرال كورتكس متباعده من بعض. الابر ليمبس هنا واللور ليمبس هنا. الفيجوال راديشن اما يطلع من الانترنال كابسول يطلع فوق عشان يصل للاوكسيبيتال لوب هنا السنتر بتاعه. الفايبرز تبدا تتباعد. جزء من الفايبرز بيمشي سوبيريورلي جزء بيمشي انفيريورلي. جزء من الفايبرز بيمر بالبارايتال لوب، جزء من الفايبرز بتاعت الاوبتيك راديشن بتمشي بالتمبرال لوب. فبالتالي لما يكون في distal disease of the middle cerebral artery you will not get homonymous hemianopia, you will get homonymous quadrant anopia. It depends. اذا كان infarction في البارايتال لوب بيكون عندك inferior homonymous quadrant anopia، واذا كان الانفاركشن في التمبرال لوب you will have superior homonymous hemianopia. دائما في النيورولوجي اي حاجه معكوسه، البارايتال لوب احنا عارفينها قاعده فوق لكن بتدينا inferior homonymous quadrant anopia، التمبرال لوب قاعده تحت لكن بتدينا superior homonymous quadrant anopia. يبقى لاحظتوا الفرق بين البروكسيمال والديستال disease of the middle cerebral artery. في البروكسيمال دائما حاجه بتكون symmetrical، الويكنس symmetrical في الابر واللور، السنسوري لوس symmetrical، الفيجوال فيلد افكت symmetrical هيمي انوبيا. لكن في الديستال الويكنس تلقاه في الابر ليمز اكثر من اللور ليمز، السنسوري لوس في الابر ليمز اكثر من اللور ليمز، الفيجوال فيلد افكت تلقاه في ربع واحد يا اما superior او inferior. الكلام عن الفيجوال فيلد افكتس كثير صعب حسي حاليا نتطرق له، حاولت بس كده اوضحها بصوره بسيطه. يبقى قلنا برضه بيكون في conjugate eye division towards the site of the lesion، بيكون في gaze preference towards the site of the lesion as we said. Remember انه الهيميبليجيا بيكون on one side والeye division بيكون to the opposite side. افيزيا بنلقاها في الدومينانت هيمسفير انفاركس، والهيمينيجلكت في النون دومينانت هيمسفير انفاركس، ومعاها ممكن يكون في برضه انوزوجنوزيا وممكن يكون في برضه ابراكسيا. طيب بعد ذاك نيجي نتكلم عن الانتيريور سيريبرال ارتري تيريتوري ستروك. الكلام هنا اقل شويه من الميدل سيريبرال ارتري، ما في كلام كثير يعني ان شاء الله. الانتيريور سيريبرال ارتري هو واحده من التيرمينال برانشز بتاعت الانترنال كاروتيد ارتري. الرسمه دي يمكن بتوضح لنا الانتيريور سيريبرال ارتري بصوره اوضح. As you can see here, this is the anterior cerebral artery. This is the middle cerebral artery, internal carotid artery. تمام. الانتيريور سيريبرال ارتري فيه برضه two parts. في البارت اوف ذا anterior cerebral artery قبل الانتيريور communicating. احنا عارفين one of the branches of the anterior cerebral artery في حاجه اسمها anterior communicating artery. ده بيعمل لنا communication between the right والleft anterior cerebral arteries وبيقفل لنا السيركل اوف ويلس. البارت اوف ذا anterior cerebral artery proximal to the anterior communicating يعني قبل ما يطلع الانتيريور communicating بيسموه A1 زي هناك M1 M2 ده بيسموه A1. والبارت distal to the anterior communicating artery بيسموه A2. لكن ما هنتكلم بالتفصيل ده بدينا نتكلم عنه بصوره عامه ما زي الميدل سيريبرال ارتري. الكلينيكال فيتشرز اللي ممكن تجينا مع الانتيريور سيريبرال ارتري تيريتوري ستروك هي ريليتد للتيريتوري سبلايد باي ذا انتيريور سيريبرال ارتري. احنا قلنا الانتيريور سيريبرال ارتري بدينا هنا بدينا الميديال سيرفيس مينلي اوف ذا سيريبرال هيمسفير، دي الكورتيكال برانشز بتاعته، وبدينا upper 1 inch along السوبيريور بوردر في اللاترال سيرفيس، دي الكورتيكال برانشز. الديب برانشز تحت بدينا الكوربس كالوزم. ما نفكر في الديب برانشز، نفكر في الكورتيكال برانشز بتاعت الانتيريور سيريبرال ارتري، دي هي دايما بتدينا الكلينيكال فايندنجز في الانتيريور سيريبرال ارتري ستروك. من الارياز importantly supplied by the anterior cerebral artery هي الupper 1 inch along the superior border here is very important because here as we know انه الموتور اريا هنا موجوده هنا في الفرونتال لوب. اذا بتتذكروا في النيورو اناتومي الرسمه بتاعت الهومونكلس بيكون الهيد والابر ليمز بيكون داون والليجز بتكون فوق وبتكون حتى ماشيه ميديالي الليجز ماشيه الميديا سيرفيس. This is very important. بتوريك انه الليجز الموتور سنترز فور ذا لور ليمز بتكون قاعده superiorly بتكون قاعده فوق في الموتور اريا. It even extends to the medial surface. It extends even to the medial surface. Here. See, the part of the motor cortex and part of the sensory cortex as well will be found on the medial surface of the cerebral hemisphere, not just on the lateral surface. This is very important لأنه part on the medial surface هنا فيه السنترز بتاعت اللور limbs بتاعت الليجز سواء motor center أو sensory center. فبالتالي when you have an anterior cerebral artery territory stroke, you will have a patient with contralateral weakness, but it will affect the lower limbs more than the upper limbs. عكس اللي بيحصل في الام سي اي، لانه الاي سي اي بتدينا mainly lower limbs. It will affect the weakness will affect the lower limbs more than the upper limbs. والsensory loss بيكون في lower limbs also more than the upper limbs. This is what happens in anterior cerebral artery territory stroke. ودي هي المين feature. طيب another important feature الاريا دي نفسها this part of the medial surface دي بنسميها paracentral lobule. الحته دي بنسميها paracentral lobule لانه ده السنترال سالكس اللي هو بيقسم لنا سنترال سالكس زي ما عارفين انه هو بيقسم الفرونتال من البرايتال لوب. الخط ده بيمشي برضه ميديالي بيجي هنا. الحته دي كلها حواليها بيسموها paracentral lobule، فيها موتور وسنسوري ارياز لللور ليمز، وفيها برضه سنتر important هنا which controls micturition. Here there is an important center responsible for the conscious and the voluntary control of the act of micturition. هنا عارفين انه المicturition is one of the spinal reflexes، يعني عشان to initiate the act of micturition بيحصل initiation. احنا عارفين انه السنترز بتاعتها في الساكرال سيجمنتس. اما البلادر تبقى distended تصل للفول كاباسيتي immediately بعد ذاك you can evacuate البلادر. لكن this evacuation of the bladder should happen in appropriate situations. يعني if someone يعني البلادر becomes distended لكن if you are in a public place you cannot initiate micturition in public place. You have to wait until you go home and then you can initiate micturition. This conscious control of micturition is controlled by an area here in this paracentral lobule area مع الموتور ومع السنسوري كورتكس حقت اللور ليمز. فاما يحصل اما الاريا دي تنضرب مع الانتيريور cerebral artery stroke you will get lower limb weakness بيكون mainly في اللور limbs ومعاه sensory loss اكثر من upper limbs، و at the same time بيكون في urinary incontinence دائما. That means انه من البلادر يبقى خلاص fully distended immediately هيحصل micturition. You cannot consciously control the act of micturition. But this is the type of stroke which will present with urinary incontinence. So if you have patient presenting with leg weakness ومعاها urinary incontinence يعني there is hemiparesis affecting the lower limbs or even monoparesis. Sometimes ممكن يكون في monoparesis only the lower limb is affected, upper limb is not affected at all. أو يكون في hemiparesis the lower limbs affected more than the upper limbs ويكون معاه urinary incontinence. Think of anterior cerebral artery territory stroke. These are important neurological findings associated with anterior cerebral artery stroke. بعد ذاك الانتيريور cerebral artery في الميديال سيرفيس هنا بيدينا important part، بدي blood supply important part of the frontal lobe اللي هي بنسميها frontal association area. الفرونتال association area هي موجوده في اللاترال سيرفيس، الجزء اللي قدام ده كله ده frontal association area، و also in the medial surface mainly. This part of the brain is very important and a lot of functions. It controls the behavior or personality. It's the part of the brain where problems are solved. A part of the concentration والjudgment. يعني كل الهاير functions يعني a lot of higher functions actually موجودة في الفرونتال association area. The ability to generate a list. يعني if you ask someone تحس الناس عندهم dementia زي frontotemporal dementia or Alzheimer's disease مثلا in advanced disease, if you gave them a paper and you ask them to generate a list مثلا you ask them مثلا to generate a list of vegetables يقول لك اكتب لستة بتاعت vegetables. You might not be able to do to generate lists due to problem because in these patients there is atrophy of the frontal association area. Patients with Alzheimer and other types of dementia, their frontal association areas are atrophied, and for that reason they have problems with the executive functions like generating lists and so on. Anyway, this part of the brain is mainly supplied by the anterior cerebral artery. So when there is an anterior cerebral artery territory stroke, the patient will start to develop features of personality and behavioral changes. For example, the patient might have inappropriate behavior. There might be disinhibition. The patient might get undressed in public place. This is inappropriate behavior. This is called disinhibition. And this is part of the behavioral changes which will develop whenever there is involvement of the frontal association area, which is supplied by the anterior cerebral artery. Also part of the personality changes, the patient might have group of disorder called disorders of diminished motivation. Disorders of diminished motivation. The patient will lack the motive. And this will lead to something called apathy. Apathy means the patient has no motive. يعني normal motive is what يعني normally when يعني لما نزول بنصحى من النوم الصباح you brush your teeth, you wear your clothes, you have breakfast, you go to work, you go to school and so on. You have a motive to do your daily activities. But if there's a pathology in the frontal association area, for example, due to anterior cerebral artery stroke, the patient will start to lack the motive. The patient might not go to brush his teeth, might not get dressed, might not go to work, he will just sit in his house, he will just lay on his bed. He will have no motive to do anything. It can mimic depression. It can mimic, sometimes it can reach the extent of akinetic mutism. And disorders of diminished motivation هي 3 درجات. الدرجة اللي أخفها بيسموها apathy. الدرجة في النص اللي هي بعد الapathy بيسموها abulia. الدرجة الأخيرة which is the extreme form of the diminished motivation is called akinetic mutism. akinetic mutism, akinetic يعني patient mute ما بيتكلم. akinetic يعني patient ما بيتحرك، ما في حركة. mutism يعني patient is mute. يعني imagine the patient will stand still، ما هيتحرك كله من مكانه، هيكون قاعد في حتته وما هيتكلم مع أي زول. This is called akinetic mutism. This is an extreme form of disorder of diminished motivation. It can happen with anterior cerebral artery occlusion. تشبه الكاتاتونيا اللي بتحصل مع ناس عندهم سكيزوفرينيا، بيكونوا قاعدين في حتتهم وزي كانوا بقى يعني متجمد في حتته. لأنه هي الفكرة شنو؟ It's not a problem related to muscles. It's not, there is no weakness. Muscles are intact. Although إنه eventually ممكن يحصل contractions وكده، لكن there is no problem with the muscles. There is no problem with coordination. Cerebellar function is intact. هنا البروبلم وين؟ البروبلم في الويل، في الإرادة بتاعت البيشنت، في الموتيف، في الحافز. البيشنت ما عنده حافز. الموتيف هو اللي بيحركنا يعني في الحياة اليومية، بيخلي الزول يعمل نشاطاته بيعملها خلال اليوم. If you lack the motive, if you lack the will, eventually you will end up with apathy or abulia, more severe or more severe form, which is akinetic mutism. دي كلها part of the personality changes which can develop with anterior cerebral artery occlusion. As you can see here, personality and behavior changes, apathy or akinetic mutism in extreme form. وفي النص بيناتهم في حاجة اسمها abulia. وممكن يكون في disinhibition. Along with that, في urinary incontinence, as well as we said. Also في frontal association area في centers regulates the primitive reflexes. The primitive reflexes بتكون موجودة في النيونات زي suckling reflex، زي الجراسب reflex. لما تاخد صباعك في البالم بتاع النيونات بيمسك طوالي كده الصباع، grasp reflex. دي بتسمى primitive reflexes. normally بتكون موجودة في early يعني part of the life. لكن as the patient بعد ذاك لما يكبر في العمر المفروض يحصل inhibition. Normally these primitive reflexes should be inhibited beyond يعني the early age. In patients with stroke, with anterior cerebral artery territory stroke, the centers which normally keep these primitive reflexes inhibited will be damaged. فبالتالي بيحصل reappearance of these primitive reflexes. So you have a patient with anterior cerebral artery stroke with grasp reflex, according to grasp reflex, which should not be there, it should be inhibited. And this is part of the areas which is supplied by the anterior cerebral artery. Sometimes patients with anterior cerebral artery can present with confusion, and this is due to involvement of specific area called the septal area. The part of an area supplied by deep branches of the anterior cerebral artery. احنا قلنا anterior cerebral artery الديب branches تدينا الكوربس كالوزم، وجنب الكوربس كالوزم طوالي في السبتم لوسيدم. This septal area supplied also by the anterior cerebral artery. إذا حصل فيها damage, the patient will develop confusion, and even there might be loss of consciousness in some cases. So that's why patients with anterior cerebral artery territory stroke ممكن يجوا confused, عندهم leg weakness, incontinent at the same time. So بعد ذاك نيجي نتكلم احنا we're talking about an anterior circulation. احنا قلنا anterior circulation, an internal carotid artery, an anterior cerebral artery, and middle cerebral artery. اتكلمنا عن middle cerebral artery and anterior cerebral artery. طيب, if there is occlusion of the internal carotid artery, what will be the type of neurologic deficits? الموضوع هنا is very simple. An occlusion of the internal carotid artery surprisingly ممكن يكون أفضل من الأوكلوجن في MCA أو anterior cerebral artery. You might think يعني ليه ان internal carotid artery هو proximal، المفروض كل ما يكون proximal كل ما يكون في more serious. لكن actually occlusion of the internal carotid artery in most of the cases it will pass unnoticed، بيكون silent. ليه؟ لأنه في الcircle of Willis. The circle of Willis is doing a tremendous job in compensating. يعني actually a lot of patients يعني if a lot of elderly patients ممكن يكون عندهم اثيروسكليروزس او اثيروسكليروتيك بلاكس موجوده في الانترنال كاروتيد ارتري وفي الكومن كاروتيد ارتريز وتكون سايلنت فور ماني ييرز. ممكن نعمل كاروتيد دوبلر التراساوند نلقى في ستينوزس. والpatient ما يكون عنده history of TIA or stroke. The reason why it will be silent is because of the good primary collateral system, which is the circle of Willis. يعني لو كان في occlusion في internal carotid artery, الposterior circulation هيمد الانterior circulation بالبلط، فبالتالي هيعوض الاوكلوجن في internal carotid artery. So stroke due to occlusion of internal carotid artery in most of the cases بيكون asymptomatic. لكن in some cases إذا كان الposterior circulation نفسه تعبان، يعني كان فيه atherosclerosis affecting the posterior circulation, at that point ممكن the patient to start to develop neurologic deficit. or المشكلة الثانية ممكن تحصل مع internal carotid artery occlusion. الاوكلوجن دائما بيكون due to atherosclerotic plaque as we said، يعني بيحصل disruption للبلاك وبيحصل thrombosis at the site of the occlusion. الثرومبوزس at the site of the occlusion ممكن ما يعمل problem لانه posterior circulation is compensating. لكن if this thrombosis has led to distal embolization, this distal emboli will go on through the circulation and it will occlude the middle cerebral artery. ممكن proximally or ممكن distally. So at that point the patient, the primary lesion is the internal carotid artery, but the patient will present with neurological deficit due to involvement of the middle cerebral artery. فدي النقطة المهمة هنا عايز أقولها. الانترنال carotid artery occlusion ممكن يكون silent أو ممكن to present with stroke due to middle cerebral artery occlusion. وهنا الاوكلوجن of the middle cerebral artery هيكون embolic occlusion. artery to artery embolism. الثرومبس هنا في الميدل cerebral artery عمل لنا embolism distally. طيب في important برضه point related to internal carotid artery. احنا قلنا واحد من البرانشز تحت internal carotid artery هو الاوفثالميك artery. الاوفثالميك artery هو برانش بيطلع من internal carotid artery قبل ما internal carotid artery ينقسم للانتيريور والميدل cerebral artery. الاوفثالميك artery والسبلاي الريتنا والاوبتيك نيرف. Patients with internal carotid artery stroke يعني occlusion of the internal carotid artery ويجيب middle cerebral artery stroke eventually. Actually those patients most of them يعني before the onset of the stroke بيكون كان عندهم recurrent history of TIAs affecting the ophthalmic artery. لأنه الاوكلوجن اللي حاصل من internal carotid artery it will throw small emboli to the ophthalmic artery. And this emboli occluding the ophthalmic artery will lead to a visual problem called amaurosis fugax. Amaurosis fugax. Amaurosis fugax is a transient loss of vision. It's a unilateral transient loss of vision. And this is due to stroke, it's due to TIA affecting the ophthalmic artery. فبالتالي البيشنتس اللي بيجوا بميدل artery territory stroke ممكن يكون كان عندهم preceding history of amaurosis fugax, which is transient loss of vision. And this transient loss of vision actually هي كانت warning sign. هي كانت عبارة عن TIAs. It should warn you that the patient in the future can develop middle cerebral artery territory stroke. عشان كده previously I talked about the mechanisms and I talked about prevention. It's important. This is the point where you can prevent stroke. Diagnosing a patient with amaurosis fugax, diagnosing a patient with TIA of the ophthalmic branch will help you to prevent the development of ischemic stroke in the future. كده احنا اتكلمنا عن الانتيريور سيركوليشن، تقريبا اتكلمنا عن كل الانتيريور سيركوليشن. نيجي بعد ذلك نتكلم عن البوستيريور سيركوليشن. في اي سؤال حد هسي عن الكلام بتاع الانتيريور سيركوليشن ده كله before we go to the posterior circulation? Any question? الصوت واضح؟ هيكون فصل ولا حاجه؟
لا ما شاء الله الصوت واضح، وعملت كفر لاي حاجه. دكتور خالد ما ادتنا اي فرصه نزعل عن اي حاجه. بارك الله فيك.
اوكي تمام. مرات السايلنس ده بخوف، يفتكر المايك فصل ولا الكونكشن كله فصل.
الأمور طيبة ما شاء الله تبارك الله.
سايلس ده والله مستمتعين طبعا بالشرح والله ما شاء الله.
شكرا لك.
الله خير.
ربنا يكرمك.
والله لأول مرة يعني في النيورو ده الواحد يعني يستمتع كده بالشرح ما شاء الله.
ربنا يكرمك يا دكتور. يا الله يكرمك.
نفع الله بك.
معلش بس الكلام بيكون كتير كده وديتيل كتير، لكن يعني حاولت تكفر الايشو، يعني دي الجراي زون زي ما بيقولوا في الستروك بالذات. يعني في بعض الكتب والتكست بوكس بيكون ديفيشنت شويه في شرح الكلام ده، يعني just give you يعني bullet points، يعني middle cerebral artery upper limb worse than the lower limbs, anterior cerebral artery lower limbs worse than the upper limbs وكده بس يعني. فالكونسبتس مهمه جدا يعني نعرف الكلام ده جاي كله من وين. طيب نمشي بعدين نتكلم عن البوستيريور سيركوليشن. البوستيريور سيركوليشن بيجينا من الفيرتيبرال ارتريز. عندنا تو فيرتيبرال ارتريز paired vertebral arteries. الفيرتيبرال ارتريز نفسها جايه من السبكليفيان ارتري. الفيرتيبرال ارتريز دي بتخش الكرينيال كافيتي عن طريق الفورامين ماجنم، نفس الفتحه الكبيره اللي بتنزل السباينال كورد. فالفيرتيبرال ارتريز بتيجي طالعه بالفورامين ماجنم. التو vertebral arteries they will join each other to form single large artery called the basilar artery. As you can see here, these are the two vertebral arteries giving you the basilar artery. الباسيلر artery الاوريجن اوف ذا basilar artery بيكون في البونتوميدالري junction. هنا الحته دي junction between البونس والميدالة. At this point the basilar artery will be formed and will ascend on a groove on the anterior surface of the pons, الباسيلر artery. بعدك الباسيلر artery will terminate at the level at the junction between the midbrain and the pons, and it will terminate by dividing into two posterior cerebral arteries. It will give you paired posterior cerebral arteries. And this is the posterior circulation. In the posterior circulation, two vertebral arteries, one basilar artery, and two posterior cerebral arteries. طيب, parts of the brain supplied by the posterior circulation هي simply the parts of the brain which are not supplied by the anterior circulation. اللي هي structures of the brain located on the posterior cranial fossa. تبدأ من فوق، تبدأ من occipital loop. ده تحديدا supplied by the posterior cerebral artery. تنزل تحت الداينكيفالون، والداينكيفالون تحديدا supplied by the posterior cerebral artery. تنزل تحته البرين ستيم. البرين ستيم نفسه الميد برين supplied by the posterior cerebral artery. البونس والميدالة ومعهم السيريبيلم these are supplied by the vertebral والباسيلر artery. ده هو basically الposterior circulation of the brain. يبقى الposterior circulation of the brain بتدينا important parts of the brain. بتدينا البرين ستيم where يعني most of the cranial nerve nuclei are found. This is an important part of the brain. في البرين ستيم برضه عندنا الريتيكولار formation اللي هي the part the fibers or nuclei which are responsible for maintaining the state of wakefulness. وعندنا برضه السيريبيلم اللي هو responsible for coordination as we know. وعندنا الاوكسيبيتال لوب اللي هي mainly فيها السنتر of vision. وعندنا برضه داينكيفالون اللي هو including الثالاموس. الثالاموس احنا عارفين انه محطه بتجيب فيها a lot of information. السنسوري information اللي جايه من تحت دي كلها قبل ما تصل للسنسوري كورتكس البرايتال لوب بتتجمع في الثالاموس، حتى من بعدك بتطلع تمشي للبرايتال لوب. فيبقى الثالاموس ده لما ينضرب with any pathology ممكن كل السنسيشنز to be affected والبيشنت يكون عنده sensory loss. السنسوري loss ما اللي يكون مشكله في الكورتكس في البرايتال لوب، ممكن تكون due to problem in the thalamus وهنتكلم عن ده هسه. ف this is the posterior circulation. طيب يبقى when we talk about the posterior circulation stroke, generally speaking, if you have a patient with posterior circulation stroke, you will have neurologic deficits related to the brainstem, related to the cerebellum, related to the occipital loop. To the brainstem هيكون عندنا features شنو؟ features related to the cranial nerves، لأنه في البرينستم عندنا cranial nerve nuclei. يعني في الميد برين as we know عندنا الثيرد والفورث cranial nerves هم الاوكيلوموتور والتروكلير. وديل اما يكون في damage في الميد برين to affect these nuclei, the patient will have diplopia. This is one of the possible neurologic findings. في البونز عندنا 4 cranial nerves اللي هم trigeminal, abducens, facial and vestibulocochlear. ده كلهم في البونز. فبالتالي البيشنت ممكن يكون عنده neurologic من the spontaneous infarction. You will have neurologic deficits related to these cranial nerves. For example, الترايجيمال nerve pulse بيدينا sensory loss, hemisensory loss on the face. بيدينا loss of corneal reflex. الفيشل nerve بيدينا facial weakness. الابدوسال nerve بيدينا also diplopia. الفيستيبولوكوكلير nerve بتدينا vertigo أو hearing impairment. في المظلة عندنا اللور 4 cranial nerves اللي هي الفيجاس والجلوسوفارنجيال والاكسسوري والهايبوجلوسال. اللور 4 cranial nerves دول مع بعض يعني when they are affected the patient will have features of bulbar weakness. bulbar weakness معناتها there is weakness of the muscles of articulations and muscles of swallowing. فبالتالي البيشنت بيكون عنده problem with articulation. There will be dysarthria. there will be problem with swallowing اللي هي dysphagia. فدي كلها features أو neurologic findings due to involvement of the cranial nerves within the brainstem. The findings these are not seen with the anterior circulation typically. They are seen in the posterior circulation. So this will help you to differentiate between anterior and posterior circulation stroke. Along with that also, for posterior circulation also there is the cerebellum. So the patient can have features related to cerebellar affection, cerebellar dysfunction. There might be ataxia, there might be nystagmus, there might be dysarthria as well. Then إذا طلعنا فوق شوية برضه still في brainstem, the patient is still in the posterior circulation stroke, the patient still can have weakness, the patient still can have hemiplegia, they can have hemisensory loss as well. Because the descending or ascending tracts, the pyramidal tracts, and NASDA or ascending sensory tracts will also pass through the brainstem, and it can get involved in posterior circulation stroke. So you can have patient with hemiplegia or with hemisensory loss, and even sometimes posterior circulation stroke can give you quadriplegia, not just hemiplegia. لأنه الbrainstem ما زي cerebral hemisphere. Cerebral hemisphere has a large surface area, but the brainstem has a smaller surface area. So infarction in the brainstem, it might affect the brainstem bilaterally. So you can have quadriplegia rather than hemiplegia in some cases. بعد ذاك involvement of the occipital loop. Occipital loop is concerned with vision, فبالتالي you can have visual field defects like homonymous hemanopia. Let's talk more specifically. ما نتكلم عن البوستيريور سريبرال، احنا نبدا من فوق، نبدا من البوستيريور سريبرال، بيبدا من تحت من الفرتيبرال ارتري وبينتهي فوق بالبوستيريور سريبرال ارتري. نتكلم عن البوستيريور سريبرال ارتري اول. البوستيريور سريبرال ارتري زي الانتيريور والميدل بيدينا برضه كورتيكال وبيدينا ديب بنتريتنج برانشز. الكورتيكال برانشز تحت البوستيريور سريبرال ارتري it will supply الاوكسيبيتال لوب، يعني دي حاجه معروفه عنه البوستيريور اللي في سبلاي الاوكسيبيتال لوب. دي المين cortical branches of the posterior cerebral artery. A deep penetrating branches of the posterior cerebral artery, it will supply the midbrain, it will supply the thalamus, the diencephalon. The diencephalon والmidbrain supplied by the deep branches of the posterior cerebral artery. ودي نقطة مهمة جدا لأنه في certain types of neurological findings will be seen when these parts of the brain are affected. هنتكلم عنها هسه. أما نتكلم من الناحية بتاعت anatomy، البوستيريور سريبرال ارتري برضه زي الانتيريور والميدل، فيه بنقسم له سيجمنتس P1 P2. هناك M1 M2 في الانتيريور A1 A2، هنا عندنا P1 P2. P1 part او P1 segment of the posterior cerebral artery ده البارت اوف ذا posterior cerebral artery قبل الجنكشن مع البوستيريور communicating artery. ده اسمه posterior communicating artery اللي هو جاي من internal carotid artery عشان to communicate مع البوستيريور circulation، بيقفل لنا السيركل اوف ويلز. البارت اوف ذا posterior cerebral artery proximal part قبل ما يطلع البوستيريور communicating artery ده بسموه P1. البارت اللي بعد البوستيريور communicating artery distal part ده بسموه P2. طيب اهميه الكلام ده في شنو؟ لانه بيدينا تو سندرومز، في حاجه اسمها P1 سندروم وفي حاجه اسمها P2 سندروم. دي الكلينيكال فيتشرز بتاعت البوستيريور سيريبرال ارتري ستروك. البي1 سندروم جاي من شنو؟ جاي من انه البي1 سيجمنت، this segment بتدينا الديب برانشز. سيجمنت البي1 سيجمنت بتدينا الديب برانشز اللي هي ماشيه تو سبلاي الثالاموس والميد برين. فبالتالي الكلينيكال فيتشرز اللي بتجي with P1 سندروم اذا كان الانكلوجن هنا بتختلف عن الكلينيكال فيتشرز اللي بتجي مع البي2 سندروم. البي2 سندروم هنا it will affect the cortical branches الماشيه للاوكسيبيتال لوب. اوكي؟ فبالتالي it will have features related to vision, related to visual field effect. طيب نشوف البي1 سندروم. البي1 سندروم قلنا it will impair the areas supplied by the deep branches اللي هي الميد برين والثالاموس. اما يكون في involvement of the midbrain، اما يكون في occlusion of P1 segment of the posterior cerebral artery, this can lead to infarction in the midbrain which is supplied by the posterior cerebral artery. Infarction of the midbrain will give you two syndromes, two main syndromes. السندروم الاول اسمه Weber syndrome which is commonly tested في MRCP exams. common question Weber syndrome. السندروم الثاني اسمه Benedict syndrome. عايزين نشوف الفرق بيناتهم. الويبر syndrome طبعا one of the main features احنا قلنا الانتيريور circulation والposterior circulation stroke both can give you hemiplegia. طيب clinically how can you differentiate between hemiplegia of anterior circulation and hemiplegia of posterior circulation؟ الهيمiplegia في posterior circulation دائما بيكون بيسموها alternating hemiplegia او crossed hemiplegia، بمعنى انه الهيمiplegia بتكون contralateral وابسيلاترالي بيكون عندنا cranial nerve pulse دائما. الالترناتنج هيميبليجيا بتجي مع البوستيريور سيركوليشن. يبقى لما يكون عندنا بوستيريور سيركوليشن هيميبليجيا ديو تو بوستيريور سيركوليشن بتكون كروست او الترناتنج هيميبليجيا. بيكون عندك هيميبليجيا اون وان سايد وكرينيال نيرف بالسي اون ذا اوبوزيت سايد. يبقى اللي بيختلف هو الكرينيال نيرف بالسي. التايب اوف كرينيال نيرف بالسي بيعتمد لنا على الليفل اوف ذا انفاركشن. الانفاركشن ده قاعد في الميد برين ولا قاعد في البونز ولا قاعد في الميدلا. اذا الانفاركشن في الميد برين الكرينيال نيرف بالسي بتاعي دايما بيكون ريليتد تو ثيرد كرينيال نيرف بالسي اوكيولوموتور، بيكون في ديبلوبيا. اذا الانفاركشن في البونز الكرينيال نيرف ديفيسيت دايما بتكون related to the facial and abducens nerve at the same time دايما، لانه الفيشل نيرف fibers of the facial nerve دايما لما تطلع من النيوكليس بتاع الفيشل نيرف في البونز it will encircle الابديوسن نيرف نيوكليوس، بتحول الابديوسن نيرف نيوكليوس وجنبهم طوالي في البيراميدال تراكس نازله، فلما يحصل انفاركشن كلهم مع بعض كده بينضربوا، فبكون في هيميبليجيا وون ذا اوبوزيت سايد بيكون في فيشل نيرف ويكنس ويكون في ديوسن نيرف بالسي at the same time. ده في البونز. في المظله تحت دايما البيراميدال تراكس بيكون جنب الهايبوجلوسال نيوكليوس، فبالتالي alternating او كروست هيميبليجيا في المظله بتكون مع الهايبوجلوسال بالسي. اوكي this is an important point. طيب البي 1 سندروم قلنا ممكن يدينا ميد برين انفاركشن، والميد برين انفاركشن ده ممكن يدينا بتو سندرومز، ممكن يا اما بويبر سندروم او بينيديكت سندروم. ويبر سندروم بيكون فيه كروست هيميبليجيا، بيكون فيه alternating هيميبليجيا ومعاها اوكيولوموتور نيرف بالسي. الهيميبليجيا بيكون كونترالاترال والاوكيولوموتور نيرف بالسي بيكون ابسيلاترال. دايما لانه البوستيريور سيركوليشن بتدينا اللور موتور نيورون كرينيال نيرف بالسي وتدينا ابر. الابر موتور نيورون كرينيال نيرف بالسي اللي بيحصل في الفيشل تحديدا بيجي مع الانتيريور سيركوليشن. البوستيريور سيركوليشن بتدينا اللور موتور نيورون كرينيال نيرف بالسي. الويبر سندروم بيكون عندنا فيه ابسيلاترال اللور موتور نيورون اوكيولوموتور نيرف بالسي with contralateral hemiplegia. تمام؟ This بيسموها crossed hemiplegia، ده بيسموه ويبر syndrome and it's due to occlusion of the posterior cerebral artery وتحديدا of P1 segment of the posterior cerebral artery. This is one of the P1 syndromes. طيب another P1 syndrome is called Benedict syndrome. You can see here. So Weber syndrome or Benedict syndrome due to occlusion of the penetrating branches of the midbrain. البنديكت syndrome تحديدا is due to infarction of the tegmentum part of the midbrain. في الميدبرين في جزء من الميدبرين called the tegmentum. لما يكون infarction في التجمنتم you will get Benedict syndrome. لأنه تحديدا في التجمنتم هناك عندنا حتة حاجة اسمها red nucleus. The red nucleus is part of the extrapyramidal system. فلما يكون في infarction at this part the patient will have hemiplegia, contralateral hemiplegia وبكون معاها chorioathetosis. بيكون في chorioathetosis، بيكون في movement disorder. Chorioathetosis is a type of movement disorder. There will be involuntary dance-like movement. اليد تمشي كده تيجي كده chorioathetosis. في نفس الحته فيها ويكنس بيكون في chorioathetosis. Chorioathetosis is due to involvement of the red nucleus. So if you have hemiplegia ومعاها chorioathetosis هنا think of Benedict syndrome which is one of the P1 syndromes اللي هو related to posterior cerebral artery occlusion. اوكي؟ دي كلها penetrating branches طبعا. طيب قلنا ال penetrating branches بتاعت ال posterior cerebral artery بتدينا الميد برين وبرضه بتدينا الثالاموس. اما يحصل infarction في الثالاموس ممكن تحصل لنا one of two things. يا اما يحصل لنا حاجه اسمها thalamic pain syndrome. thalamic pain syndrome يعني شنو؟ يعني in one half of the body البيشنت بيكون عنده paresthesia، بيكون في neuropathic pain. احنا قلنا السنسوري انفورميشن او sensory fibers كلها بتتجمع في الثالاموس قبل ما تمشي للسنترز في البرايتال لوب او في الاوكسيبيتال لوب في حاله الفيجن والهيرنج في الاوديتوري لوب. اذا حصل باثولوجي في الثالاموس الباثولوجي ده ممكن يدينا neuropathic pain، يعني البيشنت يحس ب electric like sensations in one half of the body او burning sensation which is unexplained in one half of the body. والموضوع يكون كده يعني for a long time patient is suffering from these pains. ممكن يكون multiple times diagnosed with cervical disc prolapse with cervical spondylosis and with multiple يعني different diagnoses. لكن the problem actually يكون due to a small infarction in the thalamus. This is called thalamic pain syndrome. عنده اسم ثاني named after الناس اللي اكتشفوه هم اثنين اظن، اسم كده صعب صراحه. The other possibility انه patient يجي بهemisensory loss. hemisensory loss. يعني again السنسيشنز كلها متجمعه في نفس الحته في الثالاموس. فاذا حصل انفاركشن في الثالاموس ممكن يحصل loss of sensation. يبقى this is what I want to say here. يعني هنا الهيميسنسوري loss برضه not necessarily انه يكون due to involvement of the internal capsule او البارايتال cortex parietal lobe. ممكن يكون due to involvement of the thalamus. الديفرنس الوحيد اللي ممكن نلقاه انه الهيميسنسوري loss due to thalamic infarction بيكون ipsilateral، لكن في البارايتال لوب وفي الكبسول internal capsule بيكون contralateral. Okay. And here this due to occlusion of the deep penetrating branches supplying the thalamus. يبقى the deep penetrating branches of the posterior cerebral artery, occlusion of these branches can give you thalamic pain syndrome or hemisensory loss إذا كان مشكلة في الثالاموس، ويبر syndrome or Benedict syndrome إذا كان مشكلة في الميد برين. ودي كلها بنسميها P1 syndromes. نيجي بعدين نشوف ال P2 syndromes. ال P2 syndromes هي دي due to occlusion of the P2 segment of the posterior cerebral artery. هي segment بعد ال posterior communicating artery. This is بعد ده part of the posterior cerebral artery which will give you the cortical branches. تذكروا قلنا في الحته في الميدل والانتيريور قلنا اول شيء بتطلع الديب penetrating بعدين بتطلع الكورتيكال اخر حاجه. الكورتيكال برانشز بتاعت البوستيريور سيريبرال ارتري بتدينا الاوكسيبيتال لوب اللي هي اللي فيها الفيجوال اريا الفيجوال سنتر اللي هي اراوند الكالكراين سالكس في الاوكسيبيتال لوب. فاما يحصل انفاركشن ودمج to this specific area you will get a visual field effect as well. يعني اذا كان الباثولوجي unilateral لما الستروك بيكون unilateral the patient will not become totally blind. You will have visual field effect. Again it will be homonymous hemianopia. تشبه برضه اللي بيحصل مع الميدل سيريبرال ارتري اوكلوجن. لكن هنا بيكون في ماكيولار سبيرنج. الماكيولا this is the center of the visual field. في small area at the center of the visual field بتكون spared هنا في البوستيريور سيريبرال ارتري تيريتوري. يعني بيكون في هيمونيموس هيمانوبيا بيكون في 1/2 of the visual field affected لكن في سنتر في النص بيكون intact. دائره في النص بتكون intact. الفيجوال فيلد بتاعه بيكون نورمال. لانه الماكيولا اريا دي الماكيولا اريا في الفيجوال فيلد السنتر بتاعها في الاوكسيبيتال لوب supplied by two arteries supplied by the posterior cerebral artery والميدل cerebral artery as well. دي واحده من الحتات البسيطه الميدل cerebral artery برضه will supply it. يعني الميدل cerebral artery ممكن بدي بلس سبلاي للاوكسيبيتال لوب تحديدا للحته بتاعت الماكيولا دي. فاذا حصل occlusion of the posterior cerebral artery بيدينا هيمونيموس هيمانوبيا لكن الماكيولا اريا will be normal لانه it will receive blood supply من الميدل cerebral artery and it will not be affected by occlusion of the posterior cerebral artery. عشان كده هنا بنسميها homonymous hemianopia with macular spanning. ما اعرف عندي صوره لا ولا لا. فيبقى this is P2 syndrome بتدينا homonymous hemianopia with macular spanning. طيب in some cases يعني ممكن يكون عندنا bilateral infarction في الاوكسيبيتال لوب. مثلا يكون cardio embolic stroke بتعملين امبولاي تمشي bilaterally تكفي لنا posterior circulation bilaterally posterior cerebral arteries bilaterally يحصل posterior occipital loops infarction. At this point the patient can become blind. ممكن يحصل blindness. This type of blindness is called cortical blindness. الcortical blindness فرقه شنو من الcommon types of blindness انه هنا الpupillary reflexes بتكون intact بس ده الفرق الوحيد. لما نقول cortical blindness معناتها the patient is blind but with intact pupillary reflexes. لانه البيوبيلاري reflexes ما بتصل في نهايه الاوكسيبيتال لوب. عندها different pathway من اللاترال جينيكوليت بودي بتمشي للميد برين superior colliculus بريتكتال نيوكليوس. ما نخش في التفاصيل لكن anyway ما عندها علاقه بالاوكسيبيتال لوب البيوبيلاري reflexes. فبالتالي if there is bilateral infarction of the occipital loop patient will become blind but with preserved pupillary reflexes. This is called cortical blindness. لكن اذا كان الانفاركشن unilateral ما هيكون في blindness هيكون في visual field effect in form of homonymous hemianopia with macular spanning. طيب من الحاجات برضه ممكن تحصل مع البايلاترال انفاركشن في الاوكسيبيتال لوب عندنا condition called Anton syndrome. Anton syndrome is a condition in which the patient is blind عنده cortical blindness. لما يكون في bilateral occipital infarction بيحصل cortical blindness. في الانتون syndrome بيكون في bilateral infarction patient بيكون blind. لكن المشكله شنو؟ المشكله انه البيشنت denies his blindness. البيشنت مقتنع انه هو ما blind. يعني البيشنت هو blind يعني انت بتشوفه ماشي بيقع وبيتعتر بيكون جنبه ترابيزه وجنبه ويقوم يخش فيها. He's totally blind. لكن شنو البيشنت keeps denying انه he is not blind. He's seeing something we don't know what it is but he's seeing something, he's denying his blindness. عنده مشكلة في الانسايت towards his blindness زي الانوسوجنوزيا اللي اتكلمنا عنها قبل. يعني patient is convinced انه he is not blind. And this is seen with bilateral occipital lobe infarctions. يبقى remember again ال P2 syndromes ما عدا في مشكلة في الcortical branches supplying the occipital lobe. Patient in unilateral infarction, patient will have visual field defect. في bilateral infarction you will have cortical blindness. ممكن يكون في حاجة اسمها أنتون syndrome. ده كله بالنسبة للposterior cerebral artery. لو نزلنا تحت بعد ذاك للبازلر والvertebral arteries. البازلر والvertebral arteries زي ما قلنا يعني they supply البونز وسبلاي المظلة والسيربيلم. فبالتالي clinical features بيكون related to الستراكشرز الموجودة في الارياس دي. فpatient will have cranial nerve deficits زي ما اتكلمنا عنها. ممكن يكون في lower motor neuron facial palsy، ممكن يكون في hypoglossal palsy، وممكن يكون معها alternating hemiplegia. زي ما قلنا hypoglossal palsy with alternating hemiplegia أو facial palsy with alternating hemiplegia. الكلام اللي قلنا دائما alternating hemiplegias قلنا مع posterior circulation strokes. وممكن يكون في cerebellar dysfunction features بتاعت cerebellar disease like ataxia like nystagmus. ممكن يكون عنده unsteady gait يعني. ممكن يكون في vomiting. في important point related to cerebellar infarction. لما يكون عندنا infarction في السيربيلم prognosis ممكن يكون poor in these patients لأنه السيربيلم يعني بيكون قاعد في narrow area يعني في posterior cranial fossa compared to a cerebral hemisphere. لما يكون في infarction في السيربيلم الانفاركشن بيكون معه edema. This edema will increase the intracranial pressure significantly and it can compress the brainstem anteriorly. cerebellum posterior to the brainstem. فبالتالي compressing the medulla it can lead to respiratory arrest. The patient with cerebellar infarction ممكن يجينا respiratory arrest and this is due to compression of the brainstem by the cerebellum. cerebellum بيكون swollen infarction معه edema. ده غير انه ممكن يحصل generalized increase في intracranial pressure وده يعمل لنا brain herniation كمان. دايما الcerebellar infarction ممكن يكون associated with poor prognosis. والناس عندهم cerebellar infarction البرزنتيشن بيكون دايما فيه occipital headache ومعاه بيكون في features بتاعت cerebellar disease. بيكون في ataxia, nystagmus, ممكن يكون في vomiting, vertigo and so on. Then also stroke affecting البازلر والvertebral arteries تدينا special types of syndromes. عندنا syndrome called lateral medullary syndrome. لما نتكلم عن الvertebro-basilar system vertebro-basilar system قلنا بيجينا بcerebellar symptoms، بيجينا features related to cranial nerves اللي هي زي البالبر pulses, dysphagia, dysarthria, nasal regurgitation. ده لما يكون في involvement of the medulla. الميدالة اللي عنده فيه اللور فور cranial nerves اللي هي بتدينا innervation للمسلز بتاعت الارتكيوليشن وبتاعت السوالوينج. فبالتالي لما يكون في involvement of the lower cranial nerves you will have difficulty with speech, dysarthria, you will have difficulty with swallowing. بيكون في dysphagia وبيكون مع nasal regurgitation. Along with that also ممكن يكون في brainstem syndromes. عندنا حاجة اسمها lateral medullary syndrome which is also called Wallenberg syndrome. في lateral medullary syndrome مين اسمها lateral medullary syndrome؟ لأنه الpathology is in the lateral part of the medulla. في lateral part of the medulla بيحصل infarction في lateral part of the medulla. The lateral part of the medulla تحديدا is supplied by a branch called posterior inferior cerebellar artery. The posterior inferior cerebellar artery is one of the branches of the vertebral artery. جاي من الvertebral artery. وده برضه another important يعني commonly tested condition في ال MRCP exams. بيسألوا دائما عن lateral medullary syndrome ودائما بيسألوا عن ال culprit artery يعني الارتري occluded artery. وشنو؟ ال posterior inferior cerebellar artery هو ال occluded artery في حالة ال lateral medullary syndrome وهو branch of the vertebral artery. طيب لما يحصل infarction في lateral part of the medulla في specific structures بتكون موجودة هناك في lateral part of the medulla and it will be affected. الستراكشرز دي هي شنو؟ في الرسمة دي هنا واضحة، في ما واضحة لكن يعني دي بتوضح. As you can see دي حتة فيها infarction هنا في lateral part of the medulla وأعمل لك cross section وداك lateral part of the medulla هنا on cross section. في lateral part of the medulla في important structures. من الستراكشرز دي عندنا vestibular nuclei. النيوكلياي بتاعت الفيستيبولوكوكليار نيرف بتدينا الفيستيبولوكوكليار نيرف. وعندنا حاجه اسمها الانفيريور سيريبيلار بيدانكل اللي هي دي these are fibers which will connect السيريبيلم مع البرينستم. اما يحصل damage ل these two areas يعني كلها affected في الانفاركتد area this will impair الcoordination, it will impair equilibrium. فبالتالي البيشنت will have features like ataxia, like nystagmus, like vertigo. دي كل الفيتشرز will be seen in patients with lateral medullary syndrome. لانه حصل شنو؟ حصل involvement of the vestibular nuclei وحصل involvement of the inferior cerebellar peduncle. فبالتالي ادتنا فيتشرز بتاعت vestibular impairment وفيتشرز بتاعت cerebellar impairment. These are one of the group of features seen in lateral medullary syndrome. بعد ذاك في lateral medullary syndrome also في another important nucleus affected. هي هنا لونها بني دي. النيوكليوس دي اسمها nucleus ambiguous. The ambiguous nucleus دي هي عباره عن motor nucleus for the lower cranial nerves. الكرينيال نيرفز اللي هم الفيجاس والجلوسوفارنجيال cranial nerve تحديدا these two الفيجاس والجلوسوفارنجيال cranial nerves. الموتور نيوكليوس بتاعتهم هي هنا اسمها nucleus ambiguous. If this nucleus is damaged by whatever pathology, this will impair المسلز بتاعت الارتكيوليشن والمسلز بتاعت السوالوينج which are supplied by the vagus and glossopharyngeus. فبالتالي البيشنت will have dysphagia and dysarthria. بيكون في bulbar weakness. bulbar weakness لما نقول bulbar weakness معناتها في weakness في البلبر مسلز. البلبر مسلز هي المسلز بتاعت الارتكيوليشن and speech. ومنها جاء الاسم بتاع المظله. المظله نفسها المظله اوبلونجاتا هي بسموها البلب. الاسم القديم للمظله البلب. ليه؟ لانه المظله هي اصلا اسمها البلب ومنها المسلز سموها بلبر مسلز لانه جايه من المظله لانه جايه من الكرينيال نيرفز طالعه من المظله اللي هي الفيجاس والجلوسوفارنجيس supplied by these cranial nerves. affection of this nucleus will give you dysphagia and dysarthria. This is one of also of the features seen in lateral medullary syndrome. ثاني بعد ذاك في lateral part of المظله عندنا برضو نيوكليوس ثاني اسمها spinal trigeminal nucleus. السباينال trigeminal nucleus دي هي النيوكليوس. احنا عارفين التراجيمينال نيرف عنده two functions، عنده sensory وعنده motor functions. الموتور function بتاع التراجيمينال نيرف هي related to muscles of mastication. supplies المسلز بتاعت الماستيكيشن اللي هي temporalis muscle، الماسيتر muscle، اللاترال والميديال تريجويد muscles هي عن طريق احنا بنمضغ الاكل mastication. النيوكليوس بتاعت الموتور نيوكليوس بتاعت التراجيمينال نيرف ما عندها علاقه بالمظله، موجوده في البونز لانه التراجيمينال نيرف بيطلع من البونز، لكن التراجيمينال نيرف عنده نيوكليوس في المظله. actually التراجيمينال نيرف has nuclei at each level of the brainstem. في الميد برين عنده نيوكليوس، في البونز عنده نيوكليوس، وفي المظله عنده نيوكليوس وهو بيطلع من البونز. النيوكليوس الموجوده في البونز في المظله موجوده في اللاترال بارت اوف ذا مظله، فبالتالي افكتد في اللاترال ميدالري سيندروم. الوظيفه بتاعتها هي سنسوري ما موتور، والسنسوري فانكشن بتاع التراجيم النيرف هو بيشيل لنا السنسيشن بتاعت الفيس والسكالب. تمام؟ كل نيوكليوس بتشيل لك السنسيشن من one half of the face ومن السكالب برضه، وكل السنسيشنز البين، تمبريتشر، التاتش والبروبيوسيبتيف سنسيشنز. النيوكليوس دي concerned with the pain and temperature sensations of the face تحديدا، ما عنده علاقه بالتاتش وما عنده علاقه بالبروبيوسبشن. فبالتالي لما النيوكليوس سيستم ضرب the patient will have ipsilateral loss of pain and temperature on the face. Okay? Now this spinal nucleus of the trigeminal nerve is concerned with pain and temperature sensations. So you have ipsilateral sensory loss تحديدا of pain and temperature on the face. Okay? This is another important structure affected برضو. تاني عندنا برضو another important structure اللي هي in green here. These are spinothalamic tracts. Spinothalamic tracts من اسم spinothalamic. These are tracts coming from the spinal cord and going to the thalamus. Spinothalamic. هي عبارة عن شنو؟ هي عبارة عن sensory tracts. tracts شايلين لنا sensation من تحت من الليمبس وتحديدا من الكونترالاترال half of the body، وتحديدا شايله برضه pain and temperature sensations. فبالتالي لما يحصل involvement of these tracts هيحصل loss of pain and temperature sensations لكن وين؟ contralateral half of the body. يبقى عندنا ipsilateral loss of pain and temperature on the face وعندنا contralateral loss of pain and temperature on the limbs. دي classical features بتاعت lateral medullary syndrome. هوريكم رسمه بعد شويه توضح الحاجه دي. Finally في lateral part of the medulla عندنا برضو tracts نازله اللي هي in blue هنا، دي sympathetic tracts. الsympathetic tracts دي ماشيه نازله من الهايبوثالاموس فوق، نازله في البرين ستيم وماشيه to supply الاي. تحديدا it supplies المسل في الاي اسمها dilator pupillary muscle بتعمل dilatation للبيوبل اسمها dilator pupillary muscle. وماشيه تو سبلاي اللاكريمال جلاندز في الاي اللي هي الغدد اللي بتطلع التيرز، وبرضه سبلايز السويت جلاندز في الفيس. اما يحصل interruption of these sympathetic tracts هيحصل لنا حاجه اسمها هورنرز سندروم، اللي هو بيكون فيه تراياد اوف توزس مايوزس اند انهيدروز. توزس هو dropping of the eyelid، لانه التراكس دي برضه supplies a muscle which open the eyelid which elevates the eyelid، هي اسمها levator palpebrae superioris. المسل دي supplied by oculomotor nerve وسبلايد by sympathetic fibers دي. فلما يحصل interruption sympathetic fiber بيحصل توزس، وبرضه بيحصل مايوزس، البيوبل will become constricted، لانه نورمالي السمباثيك نيرفز دي بتعمل دايليتيشن للبيوبل، فاذا حصل انتربشن للنيرفز دي هيحصل الاوبوزيت، هيحصل كونستريكشن للبيوبل. الكونستريكشن بتاع البيوبل بيجي من الاوكيولوموتر نيرف، فلما السمباثيك نيرف فايبرز دي تكون انتربتد الاوكيولوموتر نيرف هناك هيكون انوبوز، هيكون شغال بدون ما حاجه تشتغل ضده، فبالتالي يحصل كونستريكشن بيسموها مايوزس. الانهيدروزس اللي هو بيكون في شنو؟ بيكون في lack of sweat on the face، فما بيكون في sweating on the face، فدي بيسموها انهيدروز. دي هي الترايات بتاعت الهورنر سيندروم، توزس مايوزس انهيدروز، and it can be seen with lateral medullary syndrome. يبقى lateral medullary syndrome عندنا فيه loss of pain and temperature sensations from the contralateral limbs، اوكي، لكن ال loss of pain and temperature sensation بيكون في الابسيلاترال half of the face، يبقى بيكون كروست، بيكونوا كروست. لكن لاحظوا التاتش of the face والcorneal reflex will be intact، لانه احنا قلنا السباينال نيوكليس بتاع تراجيم النيرف concerned only with pain and temperature. التاتش نيوكليس والكورنيال ريفلكس نيوكليس موجوده في البونز، ما موجوده في المظله، فبالتالي it will not be affected في اللاترال ميدالري سيندروم. بعد ذلك بيكون عندنا ابسيلاترال هورنر سيندروم زي ما قلنا، بيكون عندنا اتاكسيا نستاجمس فيرتايجو due to involvement of the vestibular nuclei، بيكون في bulbar weakness dysarthria dysphagia nasal agitation و loss of gag reflex، ده كله لانه في involvement of the nucleus ambiguous اللي هي الموتور نيوكليوس بتاعت الفيجاس والجلوسوفارنجيس. دي سمبل هنا رسمه بتوريك اللاترال ميدالري سيندروم. لاحظوا on one side بيكون في loss ipsilateral loss of pain and temperature، وبيكون في contralateral loss of pain and temperature on the limbs on the body. لاحظوا انه crossed sensory loss بيكون crossed. الهورنرز بيكون ipsilateral برضه، والاتاكسيا بيكون برضه ipsilateral، دايما السيريبيلر ديفيسيت بيكون ipsilateral. اوكي، ده اسمه lateral medullary syndrome and it's due to occlusion of the posterior cerebellar artery. posterior inferior cerebellar artery دي واحده من البرانشز بتاعت الفرتيبرال artery. في ثاني كونديشن قبل ما نتكلم عن الميديال ميدالري سيندروم، في lateral pontine syndrome. lateral pontine syndrome ده due to infarction of the lateral part of the pons، وده بيكون يعني في نفس الحته او just above اللاترال ميدالري سيندروم. هنا في اللاترال بونتاين سيندروم الارتري الافكتد اسمه ده كان posterior inferior cerebellar، ده اسمه anterior inferior cerebellar، برضه branch of the vertebral artery. anterior inferior cerebellar anterior inferior cerebellar artery. اللاترال بونتاين سيندروم almost similar to lateral medullary syndrome. الفرق شنو؟ الفرق انه هنا ما في bulbar weakness، ما في dysphagia dysarthria والكلام ده. بدل البلبر weakness هنلقى في facial weakness، وممكن يكون في deafness، لانه في البونز ما عندنا النيوكليوس امبيجوس بتدينا الفيجاس والجلوسوفارنجيس، لكن عندنا facial nerve nucleus وعندنا cochlear nuclei، فبالتالي instead of البلبر weakness بيكون في facial nerve palsy ويكون في deafness في اللاترال بونتاين سيندروم. ده فرق بين اللاترال ميدالري واللاترال بونتاين. الميديال ميدالري، اتكلمنا عن اللاترال ميدالري، نتكلم عن الميديال ميدالري. هنا الارتري اوكلودد هو anterior spinal artery. الانتيريور سباينال ارتري عارفين انه سبلايز السباينال كورد، لكن اكشولي بدي قبل ما يمشي تو سبلاي سباينال كورد بدي برانشز تو سبلاي الميديال بارت اوف ذا ميدالا، الانتيريور سباينال ارتري، وده الافكتد في الميديال ميدالري سيندروم. الميديال ميدالري سيندروم اذا بتتذكروا في الاناتومي الميديال بارت اوف ذا ميدالا هي اللي فيها البيراميدز اوف ذا ميدالا، اللي هي فيها البيراميدال تراكت، يسموها بيراميدز لانه تيجي مره بعد بيراميدال تراكت، او اكشولي يسموا البيراميدال تراكت بالاسم ده لانه تيجي مره بالبيراميدز بتاعت الميدالا اللي بيكون ميديال. فلما يحصل ميديال ميدالري سيندروم انفاكشن يكون في الميديال بارت اوف ذا برين ستيم، هنا هيكون في شنو؟ هيكون في بيراميدال ويكنس، هيكون في كونترالاترال بيراميدال ويكنس، يعني يكون في كونترالاترال سباستيك هيميباريسيس. تمام؟ ومعاها ذا سيم تايم remember احنا قلنا الويكنس الهيميباريسيس او الهيميبليجيا في البوستيريور سيركيوليشن دايما بيكون alternating مع cranial nerve. الكرينيال نيرف اللي بيكون في المظله ودايما افكتد مع البيراميدال تراكس هو الهايبوجلوسال نيرف زي ما قلت لكم. فبيكون في كونترالاترال هيميباريسيس ومعاها ابسيلاترال hypoglossal nerve palsy. يكون في lower motor neuron tongue weakness due to hypoglossal nerve palsy. دي بنسميها medial medullary syndrome. As you can see, the medial medullary syndrome, the structures in the medial part of the medulla. دي pyramidal tracts هنا. وده الهايبوجلوسال نيرف. فدي هي important syndromes. ثاني آخر حاجة عندنا syndrome اسمه locked in syndrome. Locked in syndrome is due to infarction in the ventral part of the pons. في البونس. هنا البروبلم في البازلر artery, occlusion في البازلر artery اللي هو supplying البونس. Patients with locked in syndrome. Locked in يعني patient يعني زي كأنه مسجون. Trapped inside his own body. Patient. Here the patient will be quadriplegic. بيكون في quadriplegia. والpatient بيكون unable to speak. لكن البيشنت بيكون conscious. يعني consciousness is preserved في locked in syndrome لأنه reticular formation located more posteriorly. لكن هنا locked in syndrome is due to ventral pontine lesion. فبالتالي الconsciousness is preserved. البيشنت بيكون conscious لكن بيكون عنده quadriplegia ويكون unable to speak لأنه كل pyramidal tracts النازلة بيكون نازلة في ventral part of the pons وبيكون كلها affected bilaterally. So the patient will have quadriplegia بيكون في involvement بيكون في facial weakness بيكون في bulbar weakness كل الcranial nerves بتكون affected. The only intact movements بتكون هي بيكون في only preserved blinking and vertical eye movement. يعني the only way of communication the patient can have is with blinking. ممكن to blink وممكن to have vertical eye movement. لكن the horizontal eye movement is impaired لأن horizontal eye movement جاي من الابدوسال نيرف. الابدوسال نيرف بيكون affected. لكن الفيرتيكال اي موفمنت از سبيرد لانه الفيرتيكال اي موفمنت بتجينا من الاوكيلوموتر نيرف اللي هو في الميد برين فوق ونحن الباثولوجي تحت في البونس. ففي اللوكد ان سيندروم البيشنت will have quadriplegia, will be unable to speak, will have facial weakness, will have impaired horizontal eye movement, and only will have preserved blinking and preserved vertical eye movement. وبيكون في preserved consciousness. البيشنت بيكون conscious. And this is what will make things worse. And the patient is conscious and he's trapped in his own body. He cannot communicate with the surroundings. So it's very devastating for the patient. Locked-in syndrome دي not necessarily تكون due to stroke. يعني أي pathology affecting a ventral part of the pons ممكن يعمل لنا locked-in syndrome. والحاجة دي ممكن نلقاها مع tumors مثلا of the brainstem إذا كان في tumors أو sometimes certain types of heavy metal poisoning ممكن تعمل لنا زي mercury poisoning ممكن تعمل لنا locked-in syndrome. برضه ممكن نلقاها مع osmotic demyelination syndrome which is previously called central pontine myelinolysis اللي هي associated with rapid correction of hyponatremia. Osmotic demyelination syndrome one of the possible clinical features ممكن يجيبها هي locked in syndrome. Okay.
يعني يا دكتور خالد نفسه اللي بيحصل مع الكوركشن بتاع الهايبوناتريميا اللوكن سيندروم.
ايوه
نفسه.
ايوه بالضبط exactly ايوه اللي هي osmotic demyelination syndrome اسمها. هي كان اسمها central pontine myelinolysis لكن النيو تيرم هو osmotic demyelination syndrome. بيحصل برضه locked in syndrome. دايما ال ventral part of the pons commonly affected مع ال over correction of مع rapid correction of hyponatremia.
وبكون irreversible damage صح؟
Yes unfortunately يعني هو لما تصل to that point البروجنوزس دايما poor. يعني هو طبعا في النيورولوجي nothing guaranteed صراحه يعني في يعني اذا شفتوا الكيسز ريبورتس وكده في some cases ممكن تكون خدت لها خلاص يعني end results و poor prognosis و patient to recover. لكن يعني overall the prognosis is poor. يعني it's considered as irreversible يعني once it's developed. لكن as you know it's preventable.
Yeah. Thank you.
فدي كلها examples of important يعني brainstem syndromes which can develop due to vertebrobasilar system stroke. Finally, vertebrobasilar system stroke ممكن to present with coma. تعمل لنا coma with pinpoint pupils, with constricted pupils. And this is due to involvement of the reticular formation in the dorsal part, in the posterior part of the brainstem. فدي واحده برضو من يعني الورست prognosis يعني في الستروك. فالستروك طبعا is mainly is disabling disease، يعني بالذات anterior circulation. Patient with stroke usually will be left with disability. يعني it will impair his social life, it will impair his psychological state. لكن ممكن it will not kill the patient immediately unless يعني there are complications like aspiration pneumonia and urinary tract infections, bed sore and so on. لكن serious types of strokes which can kill the patient rapidly دائما بيكون مع posterior circulation like cerebellar infarctions or affecting the reticular formation leading to coma. These are يعني usually the serious types of strokes. If you have a patient presented with a stroke, the first episode of stroke, you will not just stand still. يعني still you will do everything you can to prevent another episode of stroke. يعني تعمل secondary prevention. يعني الموضوع ما كله primary prevention. Even if the patient developed an episode of stroke, you should do a maximum effort to prevent another episode of stroke. لأنه الفيرست episode ممكن تكون كانت يعني benign أو كانت mild تقول مثلا تكون بس only left the patient with disability. patient بيجي شوية عنده limp وعنده weakness في اللور limb. لكن ال subsequent stroke اللي هتيجي المرة الجاية ممكن تكون more serious. ممكن تيجي في posterior circulation تعمل cerebellar infarction. ممكن to lead to coma. ممكن to lead to one of these syndromes. It can be more serious. So بالتالي secondary prevention is very important. آخر حاجة هنتكلم عنها الليلة هي اللاكونر ستروكس أو اللاكونر انفاركتس. تكلمنا عنها قبل عن واحدة من الباسبل ميكانيزمز بتاعت الستروك. قلنا إن ممكن تكون هي عبارة عن سمول فيزل ديزيز. هي الباثولوجي في الديب بنتريتنج برانشز اللي اتكلمنا عنها هذه كلها اللي هي ممكن تكون جايه من الاي سي اي او الام سي اي او البي سي اي. فبتعمل لنا سمول انفاركتس في البرين. وعشان هي very small affecting very limited parts of the brain الكلينيكال برزنتيشن دايما بيكون very specific. يعني دايما في الستروك affecting large vessels بيكون مثلا في motor deficit ومعاه sensory deficit ومعاه language او speech deficit كلها في وقت واحد. لكن في اللاكونر انفاركتس دايما بيكون عندك isolated neurologic deficit. يعني مثلا يكون just only weakness without loss of sensation, without aphasia, without facial، او يكون في only sensory loss without weakness and so on. او ممكن يكون only problem with the speech وما يكون معاها sensory loss وما يكون معاها significant weakness. لانه الباثولوجي بيكون في small parts of the brain supplied by small deep penetrating arteries بيكون فيها pathological changes. دي ممكن تكون in form of lipohyalurosis as we discussed before، او ممكن تكون due to atherothrombosis, atherosclerotic occlusion as well. فعندنا four main يعني types of lacunar strokes. عندنا حاجه اسمها pure motor stroke. في اللاكونر ستروك احنا محتاجين نعرف التايب اوف كلينيكال فيتشر اللي هي بقى البيشنت والسايت اوف ذا باثولوجي site of the infarction. البيور موتور ستروك هنا patient will present with as the name implies with pure motor deficit. يعني بيكون في only weakness contralateral hemiparesis مثلا without sensory loss, without visual field defect, without speech problems and so on. هنا في البيور موتور ستروك الباثولوجي دائما بيكون في الانترنال كابسول. معناتها الديب بنتريتنج برانشز اللي بتكون افكتد هي الانتيكولو سترايد برانشز الجايه من الام 1 اللي اتكلمنا عنها قبل من البروكسيمال سيجمنت اوف ذا ام سي اي. ثاني عندنا another type called pure sensory stroke. البيور sensory stroke هنا البيشنت will only have sensory loss. ممكن يكون on one limb، ممكن يكون on one half of the body. هنا السايت of the pathology is in the thalamus. مشكله في الثالاموس. remember قلنا كل الثالاموس is a relay station. كل السنسيشنز تتجمع في الثالاموس. فبالتالي ممكن سمول انفاركشن هناك لاكونر انفاركت يعمل لنا شنو بيور سنسوري ستروك ودي تعتبر لاكونر ستروك. هنا الارتريز الافكتد هي الديب بنتريتنج برانشز بتاعت شنو بتاعت البوستيريور سيريبرال ارتري تحديدا البي 1 as we said previously. Then we have a condition called ataxic hemiparesis. هنا البيشنت will have hemiparesis ومعاه hemiataxia. يعني in one half of the body بيكون في hemiparesis وبيكون في برضه مشكله بتاعت ataxia as well مع الويكنس. السايت اوف ذا باثولوجي هنا برضه ممكن يكون في الانترنال كابسول وممكن يكون في البونس. يبقى الاتاكسيك هيميباريسيس ممكن تجينا من الانتيريور سيركوليشن من الميدل سيريبرال ارتري سبلاينج انترنال كابسول او تيجي من البوستيريور سيركوليشن اللي هو في البونس. فاينلي عندنا ديسارثريا with a clumsy hand. من الاسم you can understand a neurologic deficit again. Dysarthria, patient is having problem with speech, difficulty in articulating the speech. معاها بيكون في clumsy hand. Clumsy hand يعني في weakness في الهاند only. يعني patient عنده مشكلة في الهاند grip، ما بيقدر to grab stuff. لما نمسك كوباية بتقع منه طوالي. Weakness only in the hand. البروكسيمال muscles في الupper limbs بيكون normal. فبلاحظوا هنا again لاحظوا انه deficit is very limited only to the tongue and to the hand. فده الكلام اللي بنتكلم عنه في اللاكونال ستروك، انه الانفاركشن بيكون very small لانه الارتريز اللي affected small vessels. This dysarthria with clumsy hand برضه ممكن تكون زي الاتاكسيا hemiparesis. Actually it's considered as a subtype of ataxic hemiparesis sometimes. والاثنين دول ممكن يكون due to infarction في الانترنال كابسول او in the bones. هنا في سمول يعني في شويه صور كده بتوضح لنا اللاكونال انفارك. اللاكونال انفارك مرات كان بي missed on radiology on brain imaging، بالذات الناس اللي ممكن يكون ما expert يعني في البرين ايمجينج they can miss it easily. وزي ما قلنا انه في sometimes patient ممكن يكون عنده multiple lacunar infarcts وكانت silent. فلاحظوا هنا في lacunar infarcts here and here small areas of infarcts. لما قلنا lacunar جاي من lacunes، جاي من lakes of water، يعني زي كانه في small lake of water here and here. هنا mainly في internal capsule as you can see. Here also this is small lacunar infarct. دي ممكن تكون has led to ataxic hemiparesis or has led to pure motor lacunar syndrome. فدي الايديا بتاعت اللاكونر ستروكس. And prognosis usually is good في lacunar stroke. يعني usually the deficit which develops in lacunar stroke in most of the cases it tend to recover completely in most of the cases. لكن the importance here انك انت تعرف انه في important risk factors. يعني patient to develop lacunar stroke that means the patient is having most likely uncontrolled hypertension. وغير كده recently لقوا انه lacunar stroke برضه related to atherosclerosis، فبالتالي you have to control كل risk factors. يعني this time the patient has lacunar stroke but the next time the patient will have large artery stroke which can be more serious. فلحد هنا ان شاء الله كده خلاص نوقف الليكتشر بتاعت الليله. معلش تخطينا حتى الزمن اللي احنا كنا محددينه، الكلام كثير بس كان في السكشن ده. ان شاء الله هنكون لنا سيشن ثانيه. احنا بس حسي دخلنا على العيد شويه الزمن بقى ما مناسب، لكن ننسق ان شاء الله معاكم نشوف لنا يوم ثاني نعمل فيه سيشن ثانيه نتكلم عن المانجمنت اوف ستروك، ونتكلم عن مانجمنت اوف اسكيميك ستروك سوري، ونتكلم عن الهيموراجيك ستروك يعني بريفلي في النكست سيشن ان شاء الله. قبل ما نختم
شكرا
في أي سؤال؟
شكرا يا دكتور، بارك الله فيك ونفع بك. يعني
عفوا.
الشرح سلس ووافي وسيمبل الحمد لله وكلير، والواحد قدر ما كان بيحفظ يعني سبحان الله الحاجات بتضيع منه بالذات في السندرومات. يعني بعد ما انت وضحت البلس سبلاي في البدايه الامور وضحت الان، وان شاء الله باذن الله ان شاء الله نقول طلعنا من المحاضره ب 90% باذن الله. نفع الله بك وجزاك الله خير في الايام المباركات دي يا رب.
باذن الله
خير كثير
ان شاء الله.
دكتور
الله يسلمكم ان شاء الله. هو طبعا الستروك is all about anatomical correlation. انا دائما يعني بقول كده يعني انه you have to correlate clinical findings with the anatomy. يعني انت تعمل anatomical correlation in order يعني انه يكون عندك good knowledge. والكلام ده طبعا ممكن كله يتشاف ثيوري وكده، لكن actually في الجود سيتنجز يعني في الادفانس كانتريز في الديفلوب كانتريز حاليا يعني بيعملوا intra-arterial mechanical thrombectomy. يعني they go on endovascularly and they remove the clot, they remove the site of occlusion. يعني knowledge about the type of stroke. انت تكون عارف ان الستروك is proximal strokes في proximal part of the anterior circulation. It can be treated endovascularly. ممكن يعملوا thrombectomy if the patient presented within the window. This will impact البروجنوزس يعني hugely. فيعني الحاجه دي عندها clinical implication ما جاست. احنا طبعا in our practice هنا في السودان او في a lot of يعني most of the areas in the world يعني بيكون mainly targeting a secondary prevention. في acute management of stroke usually there is little that we can do. ما عندنا stroke units، ما عندنا stroke centers، ما عندنا trained stroke physicians عشان يعملوا thrombectomy، ما عندنا even thrombolytic agents which can be used for reperfusion even if the patient is presenting within the window. ده غير انه اصلا البيشنت most of the patient will present beyond the ideal window for reperfusion. هنتكلم عن الكلام ده في النكست lectures.
ما قصرت والله يا ابو يا اخي، جزاك الله كل خير، والله كان شرح يعني كافي ووافية.
الله يشكرا لك.
مشكور الله
يعني
يديك العافية.
شاكرين والله، شاكرين جدا يا دكتور خالد، يعني special thanks and appreciation، يعني وقت عظيم جدا. ومع دخول عرفة يعني بصراحة خليتنا شخصيا صالحنا مع CNS، يعني خليتنا تعافينا.
كويس الحمد لله تمام.
فشكرا جزيلا يا أخي، وكل سنة وأنت طيب
وانتم طيبين ان
يسعدك
شاء الله، وربنا يوفقكم ان شاء الله كده ببركه الايام المباركه دي.
وإياك.
ما ناخركم زياده كده ان شاء الله، معلش انه الزمن اتاخر اكثر من
احنا
الوقت المطلوب.
والله اديتنا يعني أكثر من الوقت اللي
كل عام
كنا
وانت بخير يا
نتأمل
دكتور،
فيه.
كل عام وانت
يعني
بخير، وان شاء الله في
وانتم
ميزان
بخير،
حسناتك يا اخي.
وانتم بخير ان شاء الله. شكرا لك يا دكتور. خلاص نحن عشان الزمن شويه بقى ضيق، ممكن اي زول يعني عنده اي سؤال، حتى يعني ممكن لو ريحتوا الكلام ده ولقيت يعني بقى ظهر لكم اي سؤال، ممكن في النكست سيشن ان شاء الله يعني نحاول نجاوب على الاسئله كلها ان شاء الله لو في اي سؤال مع باقي التوبيك ان شاء الله.
إن شاء الله إن شاء
في
الله
انتظار النكست سيشن ان شاء الله.
ان شاء الله.
مشكور.
خلاص تمام. خلاص يلا شكرا لكم.
شكرا جزيلا.
الله يسلمك.